Uh, Thank you. My name is Jeremy Sharib, and I'd like to introduce you to the 2026 Sarcoma Patient and Caregiver Education Program hosted by Fred Hutch. Um, I want to uh, introduce my co-host, Dr. Stephanie Schaub, who will also be speaking today. You want to say hello?
I am Stephanie Schaub. Welcome. Thank you for taking time this morning to join us. And I'm an associate professor in the Department of Radiation Oncology at the Fred Hutch University of Washington. I'm going to pass it over to Dr. Sharib.
Great. We have a really great program for everyone today. Let's be going through. Uh, Quickly, we're going to have two sessions. The first will be each will include some aspects of the medical management of sarcomas, as well as presentations from our affiliated programs, as well as some of our patient advocacy groups. We'll have programming from about 9 to just before 11 o'clock, where we'll take a quick break and then come back from about 11:10, 11:15 to noon, and we'll end right around noon Pacific. Just a couple housekeeping items. Want to make sure that everyone's aware of. This event will be recorded. You should have signed a recording permission with the registration. Throughout the event, Dr. Schaub and I, and also the participants, will be looking at the chat for any questions that you post, and we'll try to answer them in real time. Um, when you ask a question, we'll also try to repeat the question so that other participants know what the question was and understand the answer in context, because only we'll see the questions themselves. Um, if you end up leaving the webinar, we will still be here and you can come back in at your leisure. So just sign back in with the same link that you initially started with. And then just please look out for both a QR code at the end of the event to share any feedback. We'll also be sending out an email sometime this week with a feedback form. So we really appreciate your feedback. And we'll mention it at the end as well. But the Obliteride season is also coming up. Unfortunately, registration doesn't open until this week, so we can't share our link. But if you'd like to support the sarcoma team, please see that forthcoming in the post-registration email as well. So without further ado, I'm going to stop my share. And I'd like to introduce our first speaker, and that's Lara Davis. She's a physician and professor in the Clinical Research Division at Fred Hutch, where she holds the Anderson Family Endowed Chair in Sarcoma. Dr. Davis was recruited to Fred Hutch just this year as our new sarcoma program head, and she'll be walking us through the latest advances in systemic therapy for sarcoma, including some exciting developments in immunotherapy. So with that, we'd love to welcome Dr. Lara Davis.
Before we have Dr. Lara Davis present, I want to pause. It seems like a few participants, but not all, have had some issues with echoing. If you're having issues with echoing, some participants have had this resolved by exiting and re-entering, and that seems to be solving the issue. So while we're waiting for Dr. Davis to set up her slides, we'll give it about 2 minutes. That way, if anyone needs to leave and rejoin, hopefully that helps.
Thank you, Dr. Schaub. I am Lara Davis. I just want to confirm that everybody can see my slides and hear me okay. I'm getting some thumbs up. All right, great. So I'm Lara Davis. As mentioned, I am pretty new to Fred Hutch. So I'm learning everybody here, really excited to be here. It's been about 2 months, and I put together this presentation today as a whirlwind tour of what's been going on in the medical oncology portion of sarcoma care. And I'm covering things that are new within the past few years. So not all of it is new this year, but it's also, there's a lot going on in this area over the past few years. So it's pretty exciting, actually. I'm going to briefly cover each of these major topics. First, preventative systemic therapy. So systemic meaning going throughout the body, both how we choose either chemo or immunotherapy for patients. I'm going to talk about locally aggressive tumors, which are sarcoma-like tumors, but they are not malignant. They're locally aggressive. And we have some exciting new treatments for those tumors as well. GIST, or gastrointestinal stromal tumor, is one of the more common subtypes of sarcoma, and there are some new targeted therapies that have recently been approved, and then several that are in late stages of development for GIST. And then I'll wrap up with covering cell therapy and where we're at with cell therapy for sarcoma, which is a type of immunotherapy. So first, preventative therapy. This is when we're trying to prevent metastases for people that have localized sarcomas, but probably a high risk of those tumors spreading. So for patients that present with localized soft tissue sarcomas, especially in the extremities or in the chest wall or a trunk wall, these are stage 2 or 3 cancers, not stage 4 cancers. Clearly, all of those patients need surgery and radiation, and most radiation as well, in order to achieve cure. But the limitations of those modalities, as fabulous as Dr. Sharib and colleagues and Dr. Schaub and colleagues are, these micrometastases, or cells that spread from tumors that we can't see on any of our tests, are still a risk. So how can we prevent those micromets from becoming stage 4 cancer? And that's where we really try to figure out if medicines in the blood can help. So there's really a risk assessment that's key to us making that decision together with the patients and our multidisciplinary colleagues. So really, during tumor board, we're actually doing this risk assessment and thinking through which patients have a high risk and might need chemotherapy versus which patients have a low risk or an intermediate risk. And an old trial that we kind of look at in different ways over time showed us that some patients that were at high risk of these localized tumors coming back with metastases, those patients actually benefited from chemo. And if they didn't get chemo, then they didn't do well. We also learned from these trials that there was a substantial number of patients that didn't need chemo. So a lot of that risk assessment is actually happening in tumor board or before a visit. And then we will meet patients and discuss what might be recommended for that individual. The reason I'm going into this is that there's some patients where it's clearly one way or the other, but there's also some patients where they're kind of in the middle. They're lower risk, but they still have a risk. And there's also patients that really can't get, or chemotherapy might be too toxic for them. So recently, there was a trial that looked at using immunotherapy, specifically pembrolizumab, which is a checkpoint inhibitor. It's also called Keytruda. And that was given together with radiation and surgery. And the biggest caveat or asterisk with this trial is that it was really limited to a very specific subtype of soft tissue sarcoma. So while it's one of the more common subtypes, it is not for everybody that this type of treatment is beneficial. So this SARCO-3-2 trial that we talk about showed that the addition of pembrolizumab could really reduce that risk of the tumor coming back distantly in like the lungs or elsewhere for those certain types of sarcoma. So now for patients, we have this additional option for patients either that can't tolerate the chemo or that have a lower risk and don't need chemo, but that they still have a risk. And so the addition of some sort of medicine can be beneficial. So that's an exciting advance in the past few years. I'm going to move on now to locally aggressive tumors. It might make sense if there are questions as I go through all these 4 different sections. Let's do all the questions at the end so that we can kind of get through all of these different topics and then go back as needed. So locally aggressive tumors I'm including 2 different subtypes here. So one is called TGCT, tenosynovial giant cell tumor, used to be called PBNS, and the other is desmoid tumor, which is also known as aggressive fibromatosis. And these tumors don't have a metastatic potential, so they can't spread. They're not going to show up in the lungs or anything like that, but they can be quite disabling. So desmoid tumor is a tumor that can happen in any part of the body, just like sarcomas can. It's substantially more common in women. And we think that there's some sort of fibroblast that goes a little bit crazy and develops into a mass. And that mass can be pushing up against vessels. It can be invading the muscle there. It can push on nerves. It can be really painful or limiting in range of motion, or being able to go about your daily activities. What we've learned in the past few years is that actually not doing something, so not immediately jumping to surgery or cryoablation or medicine or radiation, is the first line thing to do if somebody presents with a new diagnosis of desmoid. And that's actually an advance, right? So we've learned that holding off and watching can actually benefit patients because sometimes nothing is needed. Sometimes these tumors aren't particularly symptomatic. And if we do some sort of intervention, we cause additional side effects or complications that are unnecessary. But for patients that have significant side effects, generally the first line of intervention, speaking broadly, there's lots of nuances, it tends to be medical therapy. And it's pretty exciting that in the past few years, we have a new medicine. It's a pill that can be given and actually has a pretty significant response rate. So response rate is talking about the tumors shrinking, right? One of the really interesting things about these trials in desmoid tumor is actually on the right side of the screen, plus placebo, although it doesn't have a very high response rate, it has a response rate. There's a person on this trial that had their desmoid completely disappear on a sugar pill. So this group of patients is actually why we do that active surveillance, because these patients have a benefit of just watching and waiting because their tumor on its own gets better. But this pill, for somebody who's got significant symptoms or a really big tumor, actually has many more patients that have a response with their tumors shrinking significantly and going quite a while without any growth of the tumor. So this drug is called nirogacestat, and it is available now. When was it approved? I think it was November of 24, maybe. So it's been around November of 23. So it's been around now for a little while, and we're getting more and more experience. And there's actually additional drugs that are on the horizon. So we're going to have some more treatment options. Some are still enrolling on clinical trial. That's this direct beta-catenin inhibitor has a fast track designation, but it's in clinical trials to make sure that it is actually safe and effective. Varegacestat trial is has completed the enrollment, and I suspect they'll be submitting to the FDA not too long from now. Tenosynovial giant cell tumor, the next locally aggressive tumor that we're going to talk about. This is a joint. This is a knee joint diagram here. You got your kneecap and your femur and your tibia. So this TGCT tumor, again, can't really spread elsewhere, but you can imagine if you've had all these tumor cells and inflammatory cells surrounding your joint, that it could be very painful, cause a lot of swelling and difficulty with range of motion. So we learned long ago that this is because of this CSF1 signal that leads to recruitment of a bunch of inflammation and inflammatory cells, and also the growth and proliferation of those tumor cells, which makes the tumor worse and worse. Now, typically, the really only option was surgery in the past, and repeated surgeries would often be necessary. And sometimes when multiple surgeries had resulted in recurrence, or there was some reason that a patient couldn't have another surgery, then we'd use this older pill that had some effect for sure, but often had additional side effects that so it wasn't quite as effective as we'd like, and it had side effects that were notable. So impressively, for this fairly rare tumor, over the past couple of years, we've had two very specific inhibitors, so pills, that are now FDA approved for treatment of this drug, both pexidartinib and vimseltinib. Just rolls right off the tongue. So both of those drugs are approved for the treatment of TGCT. This is another one of those kind of waterfall plots. Now you see in TGCT, placebo does not help. So a few patients may have had their tumors get a little bit smaller, but really for the vast majority of patients, it's about the same size, as opposed to with vimseltinib, which is the most recently approved drug. There's almost everybody had some degree of tumor shrinking, and some had a very significant reduction in tumor growth. So this drug's now been available for about a year, and it's taken twice a week. So it's a fairly convenient dosing. And there's actually another pill, a tyrosine kinase inhibitor. All of the other two are also TKIs that I'm not sure, but I would anticipate that they'll be submitting to the FDA not too long from now. And then another potential approach that's being investigated in trials is a CSF1R antibody. Emactuzumab also rolls off the tongue. That is particularly interesting because it's given just 5 times, so it's IV, but it's just given 5 doses, and the idea is that maybe that can keep control for quite a while. To be seen, and maybe next year we'll have more updates on the results of those trials. All right, so we're moving right along. I've got 2 more big topics to talk about, and the first being GIST, so gastrointestinal stromal tumor, and this is a unique tumor. This is a sarcoma. This is a cancer. It has it is a dangerous cancer, but it is similar in some ways to that TGTC problem in that it actually has this driver mutation, meaning that there's a mutation in the tumor cells that really causes the cancer, and that mutation is not only do we know what those mutations are, but it's actually targetable, druggable with a TKI or a drug that can, a pill. So for basically since about 2000, I think, the imatinib or Gleevec, I'm getting lots of messages, but I'm assuming that none of those are from Dr. Sharib or Dr. Schaub. So um, the first line of treatment is imatinib, and that Gleevec has been very, very effective in treating these mutations. But over time, resistance can develop, kind of just like antibiotic resistance. If you're exposing a tumor to this drug, over time, additional mutations happen and you can develop resistance. And then sometimes there can actually be resistance at the beginning. Also like antibiotics, right? We got to make sure we choose the right one. But there's a very clear algorithm of first line treatment, second line treatment, and third line treatment. And then a few years ago, in 2020, there was actually now the approval of the fourth line drug for patients with advanced metastatic GIST. This is the trial. The GIST trials all have the best names for sure. So this was the Invictus trial of ripretinib, and clearly this is an effective drug. So these kind of curves are the curves that medical oncologists look at all the time. It's basically the percentage of people that benefit over time. And this is, I think I cut it off, but I think it's years. But actually, no, sorry, it's months. And for this drug, as fourth line, so patients have already had their tumor grow through imatinib, sunitinib, regorafenib. Clearly, this is an effective drug. Then they said, wow, this is so effective. Let's do another trial and see if we can move from fourth line up to second line. And this is a very sad curve. So compared to sunitinib, which was approved for second line, ripretinib was exactly the same. So it was not going to move up the ladder from fourth line to second line because it did not beat the existing sunitinib. And due to some really exceptional science, the information that was learned in this trial was able to be expanded. So it wasn't just, oh, well, we're going to give up. There was blood testing, and that DNA in the blood from these patients with GIST was analyzed and able to identify that the patients that did better on sunitinib, the standard second-line drug, had a certain kind of mutation in their tumor as compared to the patients who did better on ripretinib. So for these patients with this certain mutation profile in their tumor, which for GIST can be determined from the circulating tumor DNA or ctDNA, ripretinib was much better than sunitinib. So they were able to determine that even though this is kind of the average response of all of these patients, if you're able to identify the mutation profile, you can figure out which ones of these patients should get ripretinib versus sunitinib. So that was what's called a retrospective look. And so the prospective look to make sure that this hypothesis is really true. Whoops, I guess I deleted it. Sorry, is a current trial that is going on called Insight. Again, GSK, GIST has amazing titles of all of their trials. So the Insight trial, which has completed enrollment now, is looking at ripretinib versus sunitinib in the second line for very specific mutations. Bevaclastinib is another drug. So these are all really an advanced trial, so phase 3 trials, and things that are happening right now. So there's kind of a lot happening in the for GIST patients right now. Bevaclastinib trial, the PEAK trial, is also looking in combination with sunitinib versus sunitinib alone in the second line. The enrollment for that trial is complete, and this some of our Fred Hutch patients were on that trial. We have IDRX 42, which is currently in trials, and I am sure that they've come up with a better name at this point. I'm sorry, I don't know what that name is right now. We're referring to it as IDRX 42. This trial is a phase 3 trial looking at this drug versus sunitinib in the second line. How in the world we're going to figure out what to do in the second line if all of these trials are looking promising? I don't know. We'll get back to you next year. And finally, there is one trial that is actually looking at first-line treatment. Imatinib has been the first-line drug for GIST since 2000. So this is a very, very important trial that we're going to certainly be following closely, because that would be a major, major change if somehow this drug is actually going to beat the one that's been around for quite a while and is well known and well tolerated and very effective. And these trials are available or will be available at Fred Hutch. All right, my last big topic, cell therapy for sarcoma. This is a huge topic. And cell therapy is a type of immunotherapy. I'm going to describe it a little bit because even people that know oncology very well get confused about these kinds of cell therapies. So there's now 2 different types of T cells. There's potentially more that I'm not aware of, but these are the main 2 that we talk about: CAR T versus engineered or TCR T cells. And almost all of the T cells or cell therapies that you've heard of thus far are CAR T cell therapies that have been used quite a bit in leukemias or hematologic malignancies. Engineered T cells are different. There's a downside in that TCR T cells have to be HLA matched, which is a really specific blood type difference that is super important and has to be tested in order to make sure that these engineered receptors actually can work within an individual's body. But the good part is that the kind of ultimate reason for why that HLA matching has to happen is that it can be effective against antigens or the protein markers of a cancer cell that are hiding inside the cell. So there's many more different targets that TCR T cells can address. Now, the good part of CAR T cells, they don't have to be HLA matched, but they can only target cell surface proteins. So in sarcoma, that's really been a limitation. CAR Ts, there just aren't that many cell surface antigens that or targets that CAR Ts can be helpful for. So that has been a limitation up till now. Synovial sarcoma, the reason I'm mentioning this is because that's the disease we actually have an approved cell therapy for, is not particularly common, but it is one of the more common subtypes of sarcomas. It often happens in adolescent and young adults, and thus far it's really been undruggable gene mutation, so different than the GIST or TGCT kind of mutations where there's a kinase that we can target with a drug. This has been very hard to find a drug to treat. Over the past several years, there have been a few different trials looking at cell therapy for synovial sarcoma and also for myxoid liposarcoma, a subtype of liposarcoma. Both of those sarcomas have a antigen, a target in common between the 2 diseases, even though the diseases are very, very different. And we have another one of these waterfall plots showing that this cell therapy, this AFAMI cell therapy, benefits a significant number of patients. This is called a spider plot. And each line is an individual patient here. And you can see that there are definitely patients that benefit and can benefit for a very long time. So this is about a year mark here. So they're in weeks. So we've got patients that got treated once here with cell therapy that are still having significant benefit. So that's exactly why we get excited about cell therapy. It's important to note that there's unfortunately plenty of patients that go on to have progressive disease after this therapy as well, however. So afami-cel is this engineered T-cell immunotherapy. It was FDA approved for advanced synovial sarcoma, metastatic synovial sarcoma, about a year and a half ago. And patients who have previously gotten chemo for their metastatic cancer and have that specific HLA blood type and have a tumor that expresses the target, which in this case is called MAGE-A4, those patients are eligible for getting that cell therapy. And we will have this cell therapy available at Fred Hutch very soon, which is great news. This is the only slide I have on all of the other cell therapies that are happening in sarcomas right now. So there are lots and lots. Does that actually have my Pinterest? Sorry about that. I did not, in fact, put the cell therapy on Pinterest. So Ledi-cel is the other cell therapy that's closest to potentially being available in clinic. It has completed the enrollment on clinical trials. The clinical trials were for both synovial sarcoma and myxoid liposarcoma. And these are also engineered T-cell, very similar to the afami-cel, but instead of the MAGE-A4 target, Ledi-cel is looking at the NY-ESO target. These trials the results have been reported in the literature, and now I believe that the process is just kind of working its way through the company and all the regulatory things that have to go to prove that this is really helping patients more than certainly that there's a substantial amount of toxicity associated with these therapies. Now, CAR T cells, those are the ones that are available to more patients because you don't have to have that HLA matching, but is limited to the cell surface targets. So B7H3 is probably the most hot topic for sarcomas because multiple different sarcomas do express that B7H3. HER2, folks may have heard of HER2, which is an important target for breast cancer, but it is also expressed on some sarcomas. So there's been quite a bit of investigation into CAR T cells for those two targets over quite a few years. I'm really, really excited that the very new CAR T cell for a target that is of interest in osteosarcoma is now available at Fred Hutch. This is a CAR T cell that was developed through Seattle Children's, and that is in trial enrolling now. NK cell therapies and tumor infiltrating lymphocyte therapies are also being investigated in many, many cancers, including sarcomas. All of that data is a little early to be talking about in these kinds of webinars, but I do think that in the coming years, we'll be hearing more and more about those. And with that, I'd like to wrap up and start seeing if there's some questions I can answer. Dr. Sharib or Dr. Schaub?
Yeah, so yeah, we're answering a couple of the ones that were easy to do, but actually a great one that I was just starting to write an answer to that would you'd be a much better person to address. Someone had asked that they were recently diagnosed, not something you necessarily spoke about, myxofibrosarcoma, and asked two questions. The first was anything that you can say in terms of new advances in immunotherapy for that diagnosis, but I think maybe more pertinent to the global audience, how do you ask about that in your medical oncology appointment?
Yeah. So, I mean, I will tell you that almost every patient that I talk to as a medical oncologist asks about immunotherapy. So you just ask. We are expecting that question. And I would anticipate that myself or any of my colleagues would be able to kind of talk to you exactly through what I was mentioning at the beginning of who might be the best candidate for chemotherapy, who might be the best candidate for immunotherapy, and it has lots to do with the type of sarcoma. So myxofibrosarcoma, undifferentiated pleomorphic sarcoma, spindle cell sarcoma, those are all actually in a very similar lump um, of what we just refer to as undifferentiated sarcomas. That's a pathologic diagnosis. And those are the ones that sometimes are responsive to immunotherapy or that checkpoint inhibitor like pembrolizumab. Most of the other subtypes are not so responsive. And so unfortunately, for those other subtypes, we don't have an immunotherapy option. And but that's a conversation for sure that you should ask about and hear what the options are.
We're running towards the next talk, but there's actually two people who asked a very similar question, and I know you have an answer for it. So, um, the question is on any new developments or new potential treatments for stage 4 leiomyosarcoma. And then if you want to end, the other one I thought was interesting was, are there any areas of research that you'd particularly like to see, us move into?
Yeah. So leiomyosarcoma, I'm sad that I wasn't able to have a section on advances in leiomyosarcoma because unfortunately we have tried, we as a medical community, and there are current clinical trials going on. There are, have been several clinical trials in the past 5 years, but we're just not making the advances that we want to make. I think the biggest advance in leiomyosarcoma is probably the idea that the combination of doxorubicin plus trabectedin or lurbinectedin, I love these names, right? Is probably more effective than doxorubicin by itself. However, it is toxic. So the big next question is, how about like sequencing them? Could, probably the real question is doxorubicin plus lurbinectedin and trabectedin versus doxorubicin by itself, and then followed by trabectedin and lurbinectedin. Could we get the same benefit without all that toxicity? And so actually that's a clinical trial that's enrolling right now at Fred Hutch is really looking at that question. Can that toxicity, making sure that it's reasonable and that the side effects are okay in order to get that benefit, and then is that benefit really there if you're kind of sequencing them instead of using them in combo. And then the areas of research. So there is a lot of exciting research going on, and not all of it makes it to this kind of talk because in the earlier stages of investigation. So in phase 1, phase 2, or even just still in mice. But yeah, I think that there is a ton of exciting research, and my particular sub interest is osteosarcoma, so I always like to see more osteosarcoma research. We've got some really cool clinical trials coming through for that. Excited about. I'm gonna take 2 seconds to say cold tumors, almost all sarcomas are cold tumors. So that is likely a problem for all immunotherapy in sarcoma, and really a major focus of research. But if you can get a lymphocyte into a big solid tumor that's cold, then potentially CAR T or TCR therapy can work. So we're continuing to try. Um, and then I
For some of
think,
the additional questions, are there any new treatments out there for liposarcoma, including
yeah,
any
so
trials here?
for liposarcoma, I think the question is specifically about pleomorphic liposarcoma, which is a very different subtype than the most common subtypes of liposarcoma. The more common subtypes, there are actually some interesting developments. So the SARC-41 trial was a trial of abemaciclib, which is a CDK4 inhibitor, and that is, I think, reporting out at ASCO this year. And so that could be a new option. We actually also have and that's for advanced or metastatic, well-differentiated or dedifferentiated liposarcoma. And we actually have a trial here trying to bring that drug into the earlier phases of treatment for that liposarcoma. So with actually Dr. Sharib is the PI of that trial, and together with Dr. Schaub, looking at, can we put surgery plus abemaciclib plus radiation together for some of these patients to reduce the risk of it coming back. So lots of cool research happening that I'm very excited about.
Another question that came in is, what is your thought about TKIs for synovial sarcoma and the prevention of micrometastatic disease?
Yeah, that's a great question. I don't know, because there aren't a lot of synovial sarcoma alone clinical trials, except for these cell therapy trials. I don't think that we've looked at using a TKI as a preventative. Certainly, chemotherapy works quite well for synovial sarcoma, so we wouldn't want. It would be risky to substitute a TKI for chemotherapy, but perhaps in addition, as more of a maintenance or a after chemotherapy kind of addition, that could be an interesting question to look at. There's certainly no data, and TKIs have side effects, so it's not a benign thing either.
I'm also going to ask, what are the upcoming exciting advancements or trials for angiosarcoma?
Yes, there's a decent amount of interesting research on angiosarcoma. A couple of the biggest trials, national trials recently have looked at the combination of immunotherapy. So first of all, there's some chemo that works extremely well. So for the most part, that's often the first line treatment. And noticing a little bit of a theme here is that our old-fashioned nasty chemos that cause nasty chemo side effects still work really well. And so finding something that is equal to or beats them in efficacy is tough. balancing out that quality of life and side effects is certainly something to consider, and that we do consider. For angiosarcoma, the combination of immunotherapy plus a TKI or similar type medicine is quite effective. Immunotherapy is surprisingly effective in angiosarcoma. So lots of interesting things that maybe next year we'll cover more on.
You. And we'll end with one just general principle type of question. If you have one type of sarcoma, such as a retroperitoneal sarcoma, that one knows it can spread, does it ever become a different subtype?
So something like very scientifically interesting question in that many sarcomas just happen. They, some crazy culmination of mutations happens, and that is the sarcoma. But there's a few of them, like the common subtypes of well-differentiated, dedifferentiated liposarcoma, that seem to evolve over time. So well-differentiated liposarcoma means that it looks a lot like normal fat. It's just growing a little too crazy. And over time, it can change into that dedifferentiated. So it's not a totally different subtype. They're related, but it would be a different diagnosis technically, and that has progressed through that spectrum. There are a couple of other similar progressions that can happen, but for the most part, one type of sarcoma doesn't become another type of sarcoma.
Thank you. That was wonderful. There are a couple patient-specific scenarios. What I would say is I would encourage you to be inspired by these talks and definitely reach back out to your medical provider team about those as well.
Yeah.
I am going to transition to the next speaker, Dr. Grace Laidlaw, who is going to be giving us a presentation on novel interventional radiology approaches for local therapy. Dr. Laidlaw is a clinical assistant professor at the University of Washington School of Medicine and the Fred Hutch in the Department of Radiology. Thank you for joining
Perfect.
us this morning.
Yeah, my pleasure. Good morning, everybody. I hope you can hear me and see my screen. Beautiful. Okay, I'm getting thumbs up. Well, yes, like Dr. Schaub said, I am an interventional radiologist here in the UW and Fred Hutch system. And my goal is to talk to you today about ablation for the treatment both of localized and metastatic sarcomas, with a goal of focusing somewhat on the evidence, but I think more from a patient facing standpoint, talking about how we do these procedures, what to expect if you're undergoing one of these procedures, and what the outcomes look like. And if you look at the scheduled agenda for today, you will see it was supposed to be both me and Dr. Ethan Hua, who's one of my colleagues and who's our site director of interventional radiology at the Fred Hutch. Unfortunately, Ethan is on call and in the middle of an emergency procedure. So I've been frantically adding a couple slides into my deck about the topics that he would have planned to have covered here. I will say we both practice interventional radiology, but in different ways. I'm not an expert in what he does, but I'll try to speak to it a little bit. And then similarly, another person who is integral to sort of our minimally invasive treatment of sarcoma patients is Dr. Peter Thurlow, who is a musculoskeletal radiologist, but who is an excellent proceduralist and does a lot of work in conjunction with Dr. Hua. And he couldn't be here today, but all three of us do quite a bit of work with our sarcoma patient population. Specifically, my clinical interests or clinical areas of expertise are in the treatment of liver tumors and lung tumors. I treat tumors that primarily arise in those organs, but also treat sarcomas metastatic to those organs. And then Doctors Hua and Thurlow specialize more in minimally invasive treatments for soft tissue and bone tumors, as well as in palliative procedures for the treatment of cancer-associated pain. So again, I will try to speak to their area of expertise a little bit, but it is not entirely overlapping with my own. I do want to say we are not the only people within the UW or Fred Hutch system who provide care to sarcoma patients. We have a big group, lots of crosstalk between our group and our children's group. We go up to children's, they come down to our hospitals as well. But certainly all of the folks that you see here are folks who you may encounter sort of throughout your journey at the Hutch or at UW. We all do biopsies, ports, lines placements, and treatment procedures as well. So certainly all of us provide care to this group. So with that, I'll talk about sort of my goals for our discussion today. I'd like to start by reviewing the evidence and outcomes for thermal ablation of localized and metastatic sarcomas. We'll discuss, I think, what is the hardest part in treating patients, which is deciding who the right patients are to provide this treatment for and when to use what modality. And then we'll review some sample cases. Like I said at the beginning of this talk, this will be a lung-focused presentation because that was really my plan for this talk or my clinical area of expertise. But I will briefly reference some of what Dr. Thurlow and Dr. Hua do. And please do come away from this talk, if you come away with nothing else, knowing that ablation can be performed in most organ systems in a safe and effective fashion. Um, all right, so let's dive in. So I think as you'll hear about in more detail later in today's set of presentations, resection and radiation are really the most commonly used local treatments. So again, not talking systemic treatments like Dr. Davis was discussing earlier, but local treatments for both localized and metastatic sarcomas. And that's because we have outstanding data and many decades of data showing that resection and radiation are highly effective, they are safe, and they're really the gold standard for treatment of these kinds of tumors. However, there are obviously going to be patients or tumors that are not amenable to resection and or radiation. Uh, and that can happen for a variety of reasons. We may be limited by prior surgeries or scarring from prior surgeries that is prohibitive for allowing our surgeons to go back in. We may be bumping up against radiation dose limits or worrying about additional damage to tissue that's already been radiated. A tumor type may not be amenable to either resection or radiation. It may not be safe to do so because of the tumor's location. Size may provide a challenge. The number of tumors may be limiting. And additionally, some patients have medical or postoperative comorbidities that prevent them from receiving these therapies. So even though these are the gold standard therapies, there certainly is a subset of patients who are amenable to undergoing treatment with these therapies. So what do we do in those patients? That is often where interventional radiologists come in with the possibility of treating patients with thermal ablation. So what is thermal ablation? It's sort of a catch-all labeling for any sort of minimally invasive procedure, usually needle-based, so using a needle or a probe that is designed to heat or cool tissue to lethal temperatures. And we can do that in a couple of different ways. There are a handful of heat-based techniques, specifically radiofrequency ablation and microwave ablation, which are designed to heat up tissue to a lethal temperature. Radio frequency ablation does that by using alternating current that's piped through a needle, heating up tissue around the tip of that needle in a very predictable fashion. And microwave ablation involves using literally microwaves, same sort of technology as your kitchen counter microwave, to make water molecules around a needle tip vibrate and heating up the tissue around that needle tip in a very predictable way. Cryoablation is a different form of thermal ablation. In cryoablation, we pipe argon gas through a tiny hole in a needle. That gas cools the needle tip in a very predictable fashion down to about minus 40 degrees Celsius, very cold. And the formation of ice crystals within cells surrounding the needle is lethal and is very effective at killing tumors, again, in a pretty predictable fashion. These are not the only forms of ablation. There are other forms. There's, ultrasound-based forms or high-intensity ultrasound-based forms, along with many other sorts of forms that I won't get into today. But heat and cold-based thermal ablation techniques are sort of our workhorses and is what we're mostly going to be talking about today. So what does this look like? On screen left, I've got some pictures. This is from an animal liver, a pig liver actually, but showing what an ablation zone looks like after microwave ablation. So the dark hole in the center of all of these areas is where the microwave needle or microwave probe was placed. You can see sort of around the periphery of all of these images, there's red tissue that is live or sort of viable liver tissue. But that lighter sort of tan tissue surrounding the ablation probe entry site, that is dead tissue, that is cooked tissue that is no longer viable. And this is what microwave ablation looks like immediately afterwards in sort of soft tissue. Microwave and radiofrequency ablation have many different applications, but in practice, we often use them in vascular tissues because it's helpful to use the heat for cautery of blood vessels. So you'll often see us use them in liver or in kidney or in areas where we're sort of worried about nearby blood vessels. But I don't want to be prescriptive with that. There are many places in the body that we can use microwave. Similarly, on screen right, I've got a picture of some cryoablation needles, and this is what the ice ball looks like when we are forming it at the edge of a cryoablation needle. So you can see these nice sort of oval or spherical ice balls that form in a very predictable fashion. Like I said, the ice is very cold, and it's the formation of ice crystals within cells that pokes holes in the cells, denatures the cells, and causes them to die. And cryoablation also has many different applications, but is often best used in sensitive tissues. So in tissues that are innervated or close to nerves, that are close to, say, the lung edge, that are close to major airways. Cryoablation just tends to be a little bit gentler and sort of more delicate. So often used in many places across the body, but in more delicate tissues, it tends to hold a bit of an advantage. So with these different kinds of ablation, both heat-based and cold-based, we really can apply these modalities for treatment of localized soft tissue tumors sort of throughout the body. So Dr. Davis referenced in her earlier talk, desmoid tumors or desmoid fibromatosis, so sort of a locally aggressive tumor of the soft tissue. And ablation, and specifically cryoablation, has proven to be very effective as sort of an adjunct or alternative treatment to surgery or radiation or systemic therapies for patients who have progressive desmoid fibromatosis or sort of more morbid tumors with symptoms. In those situations, we can insert probes through the skin into the tumor and then try to kill the tumor with ablation. And like I said, more specifically, cryoablation tends to be quite effective and well tolerated in these patients. So on screen right, you can see I've shown some images from the literature. This is a patient with a right abdominal wall desmoid tumor that was symptomatic and progressive. And this patient underwent cryoablation. We do cryoablation of desmoid tumors under a combination of both ultrasound and CAT scan guidance, usually done under deep sedation or general anesthesia because they can be long procedures, but the needles are inserted through the skin under imaging guidance. We connect the ablation probes to a setup that provides the argon gas to make the needle tips very cold. And then we watch the formation of the ice ball under ultrasound, and you can see that in the panel labeled A with that arrow that's looking at the ice ball under ultrasound. And in the bottom sort of panel, so D, E, and F, you could see we put a few probes into this tumor in order to make a large ice ball covering as much of the tumor as possible. And the arrows are delineating the area of ice ball under CAT scan. So these kinds of procedures usually take a couple hours. They're slow, but we remove the needles after the ice ball is formed, and over time the tumor slowly regresses. So a really nice way to treat desmoids, particularly in areas that are accessible by needles. Ablation is also a very versatile treatment modality for sarcomas that are metastatic to solid organs. So this was a mutual patient that Dr. Sharib sent me, I believe a couple years ago now, who had undifferentiated pleomorphic sarcoma that had metastasized to the liver. He had undergone a liver resection previously, and so in the setting of having undergone a prior liver resection, there was some scarring and loss of normal liver tissue that made it a little more challenging to go back in and resect this new metastasis that I've delineated with the yellow arrow on screen left. And so he was referred to me for ablation of this area. When I do ablation of liver tumors, I usually try to do it under ultrasound. That's the best way to do these with sort of live real-time guidance. And I could see this tumor quite nicely under ultrasound. It's the middle panel pointed to by the yellow arrow, just a small sort of dark area in the liver. I put this patient entirely to sleep. They were under general anesthesia. We watch with real-time ultrasound as we advance the needle through the skin, through the edge of the liver into the tumor, and just to the back edge of the tumor. So that's what I'm pointing out with the yellow arrow sort of on screen, right? That's the end of the probe having entirely penetrated the tumor. Then we connect our probe to an energy source. And in this case, I use microwave ablation. So heating up the tissue, again, because the liver is a very vascular organ. And so it's helpful to have a heat-based form of ablation to cauterize the surrounding blood vessels. It takes about 10 minutes to ablate these tumors. We pull the needle out. The patients are able to go home the same day. And this was what he looked like about a month afterwards. He did unfortunately progress at a different spot in the liver, but I just actually pulled up his images this morning as I was pulling these slides together. And this treated area is now more than a year out and is still entirely non-viable. So the sort of black hole that you see on screen right here, this is dead tissue. That's what you would expect to see after microwave ablation. And over the coming months to years, that scars down into just a smaller dead ablation area. So a nice way to treat liver tumors for patients who are amenable to that sort of treatment. Lastly, we'll move on to talking about lung. Ablation is certainly a versatile and pretty effective treatment modality for sarcomas that are metastatic to the lung. The lung can be a very challenging place to work. As far as I know, I'm the only person in Washington State that offers a lot of these procedures because they are hard and very time consuming. And so you need to be well resourced and really dedicated to this practice if you're going to do it. You do need to have access to a good CAT scanner that you can do procedures in. You have to be willing to work around ribs, around the sternum, and have to be willing to work quite slowly. So they can be challenging, but if you can get a needle into these tumors, as you can see here, this was a patient who had metastatic leiomyosarcoma that prior tumors had been resected. He had gotten some radiation previously, so neither of those treatments were a good additional option for him. And so I brought him in and did cryoablation to this tumor, and he did just fine. We'll look at some of his outcome images later. So certainly a nice technology, particularly in patients who have limited other option for treatment of metastatic lung tumors. So with that, I hope I've shown you at least that we can do these sorts of procedures throughout the body, in the liver, in the kidney, in the soft tissues, in the lung. And there is good evidence for the safety and efficacy of ablative techniques in all those different organ systems. Now, I don't have necessarily the time or really the expertise to talk about, say, desmoid tumor outcomes, but I do just want to sort of highlight a document that we all go off of, which is the NCCN guidelines, sort of recommending different treatment modalities for metastatic sarcomas. And there's this really nice sort of summative slide in the NCCN guidelines for sarcoma, talking about the principles of interventional oncology, meaning minimally invasive treatment of tumors under live imaging guidance. I think this is a wordy slide, but the most important part of this slide is that really, ablative techniques require multidisciplinary discussion. So if there is a patient who is under consideration for localized treatment, we talk about it as a group with Dr. Schaub, with Dr. Sharib, with Dr. Davis, and many others, talking about who would benefit from ablative therapies and sort of what the best modality would be. I think very specific considerations when it comes to talking about ablation of metastatic disease. There is outstanding evidence that local ablative treatments for liver metastases improve overall survival, particularly in patients who have oligometastatic disease, meaning disease that is just metastatic to the liver and not elsewhere. Certainly, there's good evidence supporting the treatment of sarcoma lung metastases with thermal ablation. It's safe and it's effective. Ablation is similarly effective for the treatment of musculoskeletal disease as well, particularly if it's metastatic to soft tissue or to bone. And there is a specific line in the NCCN guidelines favoring or recommending cryoablation as the ablative modality for desmoid tumors as well, particularly given evidence showing that there's good local control, favorable response rates in that specific form of disease. Um, so with that, I am going to pivot more towards talking about lung, just because that is more my area of expertise. So the remainder of this talk will be lung targeted. Um, so I get a lot of questions for the patients from the patients that I see in clinic asking me what the best treatment is for their lung metastasis. Is it resection? Is it radiation? Or is it ablation? And in general, if we can get patients to resection, meaning, complete removal of the tumor, that is the goal. But like I said at the outset of this talk, that is not necessarily an available option for all patients. And so then we come to radiation or ablation. Radiation still has sort of the longest history of evidence behind it. So it is the best established sort of next localized treatment for tumors that are metastatic to the lung. And we don't have any prospective trials that compare ablation to radiation or to resection. But certainly for patients for whom radiation is, less of an option for the reasons that we talked about previously, ablation is a very safe and effective treatment modality. And specifically, that is the case for patients who have lung metastases that I can get to with a needle that are less than 3 centimeters in size. So what is the evidence supporting that? So we do have some studies that have come out over the past sort of 15 years supporting both microwave and cryoablation in the lung. The first big microwave-based study that came out in the mid-2010s, and this was looking at microwave ablation in more than 100 patients who had both primary and secondary lung tumors. So what does that mean? That means patients who had tumors that originated in the lung and tumors that metastasized to the lung. So sort of a heterogeneous population of tumors. Additionally, the tumors could be any size. The largest tumor that was included in this study was more than 7 centimeters, which is quite large. And so correspondingly, the outcomes for this study were okay, but not great. So at 1 year, 22% of the patients who were included in this study had had recurrence at their treatment site. At 2 years, 36% of patients had had recurrence. And at 3 years, 44% of patients had had recurrence in their treatment sites. So again, not incredibly impressive results. However, when they stratified these patients by tumor size, the poor results were really driven by patients who had tumors that were larger than 3 centimeters. So those patients with tumors less than 3 centimeters had significantly better results, indicating that, maybe we should be applying this treatment for tumors that are less than 3 centimeters or so. Similarly, there was a cryoablation study that was collecting data or enrolling just about the same time that this microwave study was coming out. This is called Solstice. And they took the results of the microwave study and said, okay, well, let's just include patients who have relatively small tumors. So tumors that are less than 3.5 centimeters. This was a multi-center study. It just used cryoablation, and they enrolled patients who had 224 metastases treated. So no inclusion of primary lung cancers in this particular cohort. And the results here are more promising. Still not perfect. So local tumor control in this study, meaning tumors that either responded entirely or that had no additional growth. Local tumor control was 85% at 1 year, dropped to 77% at 2 years. The study did allow retreatment, and so they were able to improve those rates to 91% and 84% respectively for patients who received re-ablation of that target tumor. So more promising results with cryoablation in this sort of smaller tumor patient population. And so more recent studies have taken that even further. So this is a really nice study that came out of a couple of East Coast institutions just a couple years ago, looking at both microwave and cryoablation in patients specifically with sarcoma lung metastases. It's a smaller study. They only enrolled 27 patients, although those patients had 65 sarcoma pulmonary metastases metastases treated during the study period. And all of the metastases that were treated in the study were less than 3.5 centimeters, relatively contemporary study, so from about 2009 to 2021. And the study authors stratified patients by those who had tumors that were less than 1 centimeter or greater than 1 centimeter. And for tumors that are less than 1 centimeter, the 2-year local control rates are outstanding. So 95% for microwave, 98% for cryoablation. That's effectively the same for either modality. The outcomes are less good, but still reasonable for tumors that are greater than 1 centimeter. So 2-year local control rates of 62% for microwave, 79% for cryoablation. And again, even though it seems like those numbers sort of favor cryoablation here, this is a relatively small study, so no statistically significant difference between microwave or cryoablation here. But certainly a study recommending or sort of supporting the idea that if we can ablate tumors when they're small, 1 centimeter or less, that gets patients the best set of outcomes. So that's really what I try to do when I see patients in clinic is, if I can get to a tumor when it's small, that is certainly my goal. And I know that I'm going to be able to get better outcomes in that situation. So that brings me to sort of the next set of questions that patients and I talk about in clinic. Who is this going to benefit? Who is the right person to offer ablation for? And I see plenty of patients in clinic who are great candidates for this. So on screen left, I've shown you a picture of just such a patient. So patient with a single solitary tumor, pretty deep in the lung, so would require a big lung resection, so not necessarily a great surgical candidate, and a very young patient with a tumor that's relatively small, where it was felt that radiation wasn't necessarily going to be the best option. So in this patient, small tumor, single lesion, relatively easy to get to through the skin. This is a great candidate for ablation. I do also see plenty of patients in clinic who I have discussions with that ablation may not be the right choice for them. And the reason why is patients who have lots and lots of lung tumors probably won't benefit from me targeting a few or a handful of their tumors with needles. And so my society, the Society of Interventional Radiology, says that in general, when I'm thinking about offering ablation to somebody, it should be a patient who has control of their primary site of disease. So no residual large or growing tumor at their primary site of disease. They should have a limited number of small lung metastases, and that's a deliberately vague statement because every patient is a little bit different. But again, not 20 or 30 metastases, but something more reasonable. And they should have relatively good disease biology, meaning they shouldn't have rapidly progressive metastases or metastases that popped up immediately. We should be ideally treating patients we think have the disease biology to respond well to the treatment. So I know that that's a vague statement, but again, it is deliberately vague to allow us a little bit of wiggle room to personalize treatment for patients. But again, a limited number of small lung metastases, that's a reasonable sort of patient population to apply this treatment for. I also talk to patients quite a bit about how I choose modality. Since I told you at the start of this talk, there are both heat-based and ice-based or cold-based treatment modalities. I tend to favor cryoablation in the lungs. Like I said, it's a gentle treatment modality. So particularly if I'm close to major airways or if I'm close to the edge of the lung, cryoablation will be better tolerated and generally safer. Microwave or radiofrequency ablation can also absolutely be used in the lung. It just needs to be used with caution near the edge of the lung or near major airways because it can actually cause heat or thermal injuries to those areas. So you do have to be a little bit more cautious with it. So with all of this in mind, what does this look like for patients? This is not a picture of me, but this is exactly what my setup looks like. So we do these procedures in a CAT scan room. So I am basically getting near live CAT scan imaging of my needle as I am moving it throughout the the duration of this case. Patients are either under general anesthesia, particularly if I think a spot's going to be really hard to get to or if it's going to be a long procedure. But if it's a pretty straightforward spot or just a single spot and relatively short procedure, I will do these with conscious sedation only, meaning not having a breathing tube in. Um, you are laying either on your belly or on your back in the CT scanner. You are covered with a surgical drape. I am surgically prepped as well, so it's a sterile procedure field. And it's not a big incision at the chest wall. For those of you who are familiar with gauge size, the needles are between 14 and 17 gauge, so just a couple of millimeters each. And so really you just have small 2 to 3 millimeter incisions at each needle site as it goes through the chest wall. The procedures are long. They're between an hour and a half to 3 hours, depending on the number of tumors that I have to treat and how challenging it is to get to those spots. And when I pull the needles out, there's certainly a possibility that some air leaks out of the lung and that I have to place a chest tube. So in about 50% of patients or up to 50% of patients, I'll tell people that there is a likelihood of getting a chest tube, which I can also place under CT guidance. I keep all patients for overnight admission after I do these procedures, but I'm almost always able to send people home the next day. So I'm going to close just with showing you a couple of cases that I've done, so you get a sense of what these look like and what the outcomes are. So this was one of the first cases that I did here at UW a couple of years ago. 22-year-old patient, not a sarcoma patient actually, had metastatic liver cancer, primary liver cancer, but had developed a solitary right upper lung metastasis with multidisciplinary discussion, not a good candidate for resection, not a good candidate for radiation. And so we discussed doing ablation for him. So did general anesthesia for him, used a single probe that I advanced through the skin into the tumor, which you can see second and third panels from screen right. All of the white that you can see sort of in the middle panel around the probe, that is the ice ball and a little bit of surrounding liquid or hemorrhage that develops around the ice ball itself. But we took the needle out after freezing the tumor. He did not get a chest tube, did not have leakage of air from the lung, discharged the same day, and I now have 18-month follow-up for him, and that tumor is gone. So really an outstanding response and couldn't have asked for anything better for this young patient. I know there were some questions specifically for Dr. Davis in the last section about solitary fibrous tumor. This was a 57-year-old woman with solitary fibrous tumor, the right chest wall that had been resected. It had metastasized to the lungs. She'd had prior resections, not a great candidate for additional prior resections or for radiation because she had 5 small right-sided metastases. And so she was referred to me for ablation. I have treated 4 of these now. I'm still waiting to treat the last one, doing these sort of in a staged fashion. But treatment of her initial 4 went just fine. So in this case, I put 2 cryoprobes in to target this particular lesion. I wasn't able to get a probe right down the middle of it due to an intervening rib. Did the same sort of thing for another spot or another tumor that was a little lower down in the lung. In this case, in order to work around the ribs, I had to put the probes at sort of different angles, and that's what you can see on bottom screen right. And then she had 2 additional lesions that were lower down in the lung, and I was able to get a probe on either side of each of those and then sort of create one giant ice ball around them. I did all of this under general anesthesia. This was done over 2 different procedures for her, just to allow recovery in between each of them. I have 9-month follow-up for her now. She is on systemic therapies that inhibit wound healing. And so her tumors or the ablation zones haven't shrunk down quite as much over time just because she does have impaired wound healing. But you can see at 9 months, this sort of thickening in the region where we did the ablation zone is slowly shrinking down. And as we watch over time, that will continue to shrink down into something that's just a linear scar. This is a 67-year-old man with a chordoma, so a different kind of soft tissue tumor that had metastasized to the lung. He had 2 sub-centimeter lung nodules, wasn't a great candidate for radiation and did not desire surgery. And actually, biopsy to confirm the pathology or the histopathology of these tumors was requested at the same time that I did the ablation. And that is something that I can do. I can combine lung biopsy with ablation as long as I have enough room to get the needle in place. But that is what I did for him. So these were small tumors that were close to the bottom of the lung where there's quite a bit of motion usually with breathing. And so I did this procedure under general anesthesia for him to really be able to control his breathing. Put the probes in place, put a biopsy needle right in between all of them, took a tissue sample, did the ablation. You can see here on screen right after I pulled my needles out, I'd stuck several needles in his lung at this point. So there was a small leakage of air from the lung. And that's what the arrow is showing, just that sort of black rim around the lung. But that didn't enlarge at all. So he did not require a chest tube. The biopsy was diagnostic, so confirmed chordoma. And I just saw him back on clinic on Friday, so I didn't have a chance to get his images in my PowerPoint. But these two tumors are dead. There is no residual viable tumor at those areas. I'll wind up treating a couple of other small metastases that have popped up for him, I think in the next couple of months. I know there were questions about leiomyosarcoma in the last section. This was a 67-year-old gentleman, metastatic leiomyosarcoma. He'd had his primary both resected and radiated. He'd also had resection and radiation of multiple other lung metastases, and he had two residual pulmonary metastases that were not great candidates either for resection or for additional radiation. So he came to me for ablation of those. On screen left, you can see one of these metastases. This one's a little bit larger, just under 2 centimeters. I was able to put two probes on either side of it. And he actually started bleeding quite a bit during the procedure. You can see all of that white sort of around the probe on the panel that's second from the left. That is a little bit of blood product. So he did cough up a little bit of blood from his breathing tube during the procedure, but it actually wasn't an issue at all. It was self-limited, stopped on its own. I didn't have to do anything. And you can see I have 6-month follow-up for him, and that area is collapsing down really nicely. No residual sort of scarring or residual blood products in the lung at all from that. The other lesion that I was targeting was a little bit lower down, and I did this at the same time that I was ablating that first lesion that I showed you at the top of the screen. This was a small tumor. I was able to just get one needle into it and ablate it, so froze it with ice as well. Unfortunately, when I pulled that needle out, he developed a leakage from that area of air, and the leakage was significant. It's a substantial amount of air. You can see sort of that black area outside the lung. So I immediately put a chest tube in. He had to have the chest tube in for a couple days. I kept him in the hospital for 3 days until the leakage of air stopped on its own and we got the chest tube out. But you can see on screen right, that is his 6-month follow-up. That tumor also looks dead. I don't see any residual solid tissue there, just a little bit of scarring around the ablation zone. So really nice outcome for him. So with all of that, I will wrap up. I know I'm getting close to time here, but I hope through this very lung-focused talk that I've been able to show you that thermal ablation is an effective treatment modality across many sites for both localized treatment of sarcoma, but also treatment of sarcoma that is metastatic to many sites. Certainly, it is safe and effective for tumors that have metastasized to the lung, and particularly effective for tumors that are quite small. So with that, I will stop right there. Thank you very much for your time, and I'm happy to take questions.
Thank you,
That was
Dr. Laidlaw.
wonderful.
That was excellent.
Thank you.
Um, so we have a couple of minutes for questions. Actually, your timing was perfect. One that actually came from the audience, which might be a nice kind of summary or synthesis of some of the terms you're using. So you often had used the term effective when
Hmm.
talking about ablation, and just from kind of the patient perspective, we might not be as familiar with that. Is that meaning a local control for a period of time, and overall survival, even just an efficacy, or how are you using
Yeah.
that?
Yeah, it is a great question. And it really depends, I think, on what the patient goals are, right? For the patient I showed you who had a solitary lung metastasis and no other disease, my goal for that patient is curative, right? So when I talk about effective for small tumors, say tumors that are less than a centimeter in the lung, efficacy for me means complete response and means cure. And so that's why I sort of show the paper that compared cryoablation and microwave ablation for tumors that were less than a centimeter, sarcoma metastases that were less than a centimeter in the lung. I want to see at minimum control rates, meaning uh, disappearance of the tumor on radiology or no additional growth of that tumor on radiology, I want to see local control rates that are high, more than 90%, because to me, that's a meaningful sort of outcome for the patient. Now, certainly for patients where the treatment intent is more palliative, um, we may just be looking at, say, shrinking the tumor, but knowing that it may come back at some point in the future. So I think talking about efficacy depends a little bit on what the patient goals are, curative versus palliative. And so I realize I use those terms a little bit interchangeably in the talk.
Great. Thank you. That helps clarify things. Question that came up, I think this is maybe an interesting conceptually, is whether ablation is only for metastasis from tumors or can it be used for original tumors as well?
Yes. So it really the answer is it depends. Mostly what it depends on is tumor type. Um, because again, we use ablation not just for sarcoma or sarcoma type tumors, but for many other types of tumors as well. I would say that in the sphere of sarcoma, oftentimes we are using ablation for metastatic disease, as opposed to for treatment of the primary tumor. Um, that's not true in every patient or in every modality. So, for instance, in desmoid fibromatosis, we may be using ablation for treatment of the primary tumor itself. But I would say in the sphere of sarcoma in general, we are often using ablation for the treatment of metastatic disease.
Excellent. And we just have one more minute. I think this is probably a shorter question, but is Fred Hutch offering pulse electric field ablation for lung
Yes.
metastases? I actually don't know what
Yes.
that is, so maybe a couple words on that as well.
Yeah, it's a hot topic. It is an old technology that has recently come back into fashion. So it is post-electrical field ablation involves sending a brief electrical shock. Again, it's a needle-based technology, but it transiently creates small pores or small holes in cells, and is an effective way of sort of lysing tumor cells. Um, there is a device that was recently FDA approved in the past year for the treatment of metastatic disease, both in soft tissue and in lung. The device is called Aaliyah. We do not have it at Fred Hutch at the moment, in part because the outcomes data are still somewhat limited. But certainly, if it is something that you are interested in, it is always worth talking to your oncologist about it. And certainly, there are sites in the Pacific Northwest in general that do have access to it, and I'm happy to provide referrals to those as needed. But all of this is to say we are not currently offering PEF at Fred Hutch.
Excellent. Well, Dr. Laidlaw, thank you so much for that really insightful talk. I'm going to welcome our next speaker, Dr. Chris Lewis, who is an assistant professor in the Department of Rehab Medicine at the University of Washington, and the Fred Hutch Specialty Chief Clinical Information Officer for Rehab Medicine as well. And he'll be speaking on the role of physical therapy in the sarcoma care, which is very top of mind for many patients. So please welcome Dr. Lewis. Thank you.
Fantastic. Yeah, thank you for the introduction. Really excited to share, what we do in rehabilitation medicine. So, I focus on, or I guess in PM&R, which is my specialty, physical medicine and rehabilitation. But we really focus on function. So we're focusing on how can we help patients get back to the activities and mobility and things that they really want to get back to. So I'm going to talk through just a few of the ways that we do that, as well as focus on lymphedema management. So one of the common phrases or concepts we talk about is resiliency. And so there's an element of, the ability to bounce back after having, something happen. And so we think about this in terms of, materials such as rubber. But, it can be hard if we get a really big stretch in our lives to really bounce back to that original shape. So part of what we're trying to do with rehabilitation is help absorb that strain and get back to that, original shape. So why is this important? And kind of what is going on in the field of medicine and rehabilitation. So this is just a quick uh, graph just showing how much rehabilitation in cancer is showing up in the literature. So this is just since 20 or the year 2000, but we can see the number of PubMed searches have really increased over the years. And I think one of the things that I think can be helpful to visualize this is this graph here. I'll just kind of click through and have appear. But essentially, when we're talking, one of the concepts that we think about is prehabilitation, or improving functional capabilities before a surgical procedure. And the idea behind this, the y-axis here is really physical function and level of independence, and the x-axis is time. So, throughout our lives, our physical function and independence goes down just through healthy, normal aging. But, when we get a cancer diagnosis or, a new medical diagnosis, the physical function and independence can decrease a lot quicker. We may have surgery or other treatments, and that can, really decrease our physical function in a short period of time. What we want with rehabilitation and rehabilitation in general, when we're thinking about getting exercise in before treatment and during treatment, we want to slow that trajectory and really decrease the slope so that we maintain more function throughout the treatment that we're receiving. So a lot of what we're talking about with resiliency is maintaining that function throughout the recovery and survivorship. And our goal is to really help you through that process with our multidisciplinary team at the Fred Hutch. So yeah, just taking it back to resilience and our ability to maintain that psychological and physical functioning in the face of these stressors. So why is exercise so important for this, and why when we're talking about specifically physical therapy and the other exercise modalities that we have? A long time ago, when we're thinking about getting sick, the big thing was take time in bed, rest and recover. And I think we really know in the data and the literature, and what we're finding is it's important to be active throughout an illness, or like we're talking about when we're being stretched. It's important to maintain activity as much as it's safe and as much as possible. So bed rest really isn't the answer anymore. So, oncology providers and a lot of societies and groups that are researching this have found and recommend that we really should start aerobic and resistance exercise during active treatment to try to mitigate the side effects of cancer. When we go through the treatment process, there's really a lot of things that can happen listed here, just to name a few. It can impact our bone health, our cardiovascular health, our mood, and challenges with sleep. And so these are all things that I really see a lot in the folks that I'm helping manage. And it's, really helpful. And I think we find it very helpful to think through these, side effects and the consequences of treatment, and think, how can we, be active, and how can we do this safely? So the ACSM, or the American College of Sports Medicine, has put together, I think, some really good resources for this. I just find this infographic helpful, just to show, what are the things that we think about that cancer how it can impact our lives, as well as maybe some simple recommendations for some specific exercises and opportunities. So really, typically when I'm first meeting folks, we're thinking through these different categories on the top. Which of these are really impacting them? And then from there, trying to come up with exercise plans, nutritional plans, changes, medications, things we can try to help streamline and improve these different areas. And we kind of join on this journey together, and it can be a process depending on what's going on with the medical management. But we really join in and, come alongside and find how can we really customize an exercise plan to what you find helpful and what you're able to tolerate. So, it's not necessarily a single prescription or a single treatment plan or exercise plan. We really try to customize it to what your function is at the moment. And we have an excellent team of physical therapists at Fred Hutch Cancer Center, as well as colleagues around the region who help people have access to physical therapy. If you live further out of the city, we can help get you connected with different teams to further refine the exercise plan at home um, uh, from what we initially start up. So there's a lot of opportunities here to think through these. One other piece of framing that I think is really helpful when we're thinking about recovery is the term pacing. And I might ask, folks, when I'm first seeing them in clinic, is this something you've heard about? And a lot of them are hearing about this earlier and earlier in the process. I'm finding as it becomes more of a mainstream concept. But I think, when we think about pacing, when we're hiking or walking or running, it's really trying to find a pace of moving forward that we can maintain. And so we're not going all out super hard running at the beginning only to become exhausted before we reach the finish line. So it's finding that appropriate pace that's customized to us, make sure that we're still moving forward. We're able to, do something every day and make progress towards our goals. So I think this figure I find is helpful to visualize, what we're talking about. The top figure here shows, if stamina is on, again, the y-axis and times on the x-axis here. If we're not pacing, we're really having these high peaks and valleys where, the amount of energy we're putting in one day might be 110%, and then the next day we just feel so exhausted that we can barely, put in 20%. And so we have these high peaks and valleys, and it's really hard to it can not only be hard to make progress physically, but it can also be, psychologically frustrating to have these good days and bad days and have such a change in function day over day. So with pacing, we really try to have more consistent daily energy usage where we plan out our activities and really try to build in rest. So what I might say is if there's chores you're doing around the house or other activities, if you're unloading the dishwasher, mowing the lawn, breaking it into smaller bites. Sometimes we even use the phrase, exercise snacks throughout the day. So instead of trying to do full hour of exercise, which you may have been able to do beforehand, trying to fit in little pieces of exercise throughout the day, so that we get to, the same number of maybe minutes throughout the day, but we find that people are able to maintain a lot more energy, and find that it's not as exhausting, and they're able to maintain a similar level of activity. So this can be a great schedule, or it's really a great scheduling strategy where, you try to pair little exercises with things you're already doing. So it might be brushing your teeth or, when you're eating, just before or after eating a meal, trying to pair some just simple exercises, stretches, and this can really be customized to what you're specifically dealing with regarding different joints or different areas of your body. I see a comment in the chat. So if there's any comments or questions, we can take those at the end as well, but feel free to chime in if something comes up. So for establishing a routine, I was kind of mentioning this a little bit earlier, but really I think it can be helpful to pair exercises we do with things we enjoy. So it can be pairing it with, if I do the exercise, I get a reward and a snack I enjoy, or I really like listening to books or music. And so adding things that we enjoy to the exercise can be helpful. Also, I think some people find kind of the gamification of the process very helpful. They like tracking, they like seeing their improvements on their exercise app. There's a few listed here, and there's dozens and dozens out there. But essentially, you can see I took this many daily steps this week, and now I'm up to this many steps. And we typically recommend, about a 10% increase in activity per week. So if you are using a tracker, if you're hitting around 3,000 steps a day at the very beginning, trying to, for the following week or week two, hitting maybe 3,300. So trying to increase that by about 10% per day. And that lets us make sure that we're, making progress without having too large of jumps where we really experience maybe a significant increase in daytime fatigue. We also really encourage social support. So there's a lot of community support groups and other groups in the Seattle area, and we can work on finding places more locally as well. Or having an exercise partner, someone to do this with, to make it not only accountability partner, but it can make it more fun to have someone going through this with. And then I think just want to always call out that there can be setbacks. There's going to be ups and downs, even when we're pacing, even when we're doing everything. And that's totally, part of the process. even these little exercise snacks are still a win. And sometimes, slowing down or decreasing a little bit of the activity is what we need to just keep moving forward. I also want to bring up lymphedema. I think this is a very common, complication we see, and we also help manage in the rehabilitation team. Our physical therapists are experts in helping manage lymphedema. So just in brief, what is lymphedema? I think this is something that, patients again are hearing earlier and earlier in their process. But just starting out with what is lymph. So lymph is this fluid, typically a protein-rich fluid that bathes all of our cells. It's usually, released in, through the capillaries, and there's just this area of nutritious, protein-rich fluid that, like I mentioned, brings nutrition to the cells, but it also picks up, debris, viruses, other things, and then helps bring that back and filter it through our lymph nodes before going back to our main circulation. So I know most people know about their arteries and veins and how the blood flows back, but there's also this system to help pull additional fluid back, and that's the lymphatic system. And so the lymph pathway is very vulnerable to damage, and it can pick up cancer cells and other things and become kind of a part of or one of the locations where cancer can spread. And so when we're thinking about the lymphatic system, radiation and other treatments, surgery can damage the lymphatic system, as well as the location of a tumor can compress it, so that a limb typically is where we see it, is where a limb may start having additional fluid buildup. And so, just on the bottom here, some of the common symptoms we see, if you're looking out for this yourself, is swelling, and typically, like I mentioned, the arm or leg. The skin might feel firmer or tighter. You may feel heaviness or tightness in the limb, or just it may be harder to move the joint itself because there's just more tissue to move. And so this is a common complication we see, then we can also help manage. So how do we typically treat this? There's a few things we focus on. There's a couple stages, and I think this figure, shows this really well, that the two phases are really interlinked, and we're thinking through maintaining the limb and decreasing the edema. But really the initial part is the decongestion. We're really trying to get as much of the fluid we can, or the lymph, out of the limb. This is mainly done through this complete decongestive therapy, where we're manually draining, like massaging the limb. And this is what the therapist can perform and help teach you, is how to massage the limb to really push the fluid out. We also bandage them to help with maintaining the compression between the treatment sessions. So they'll do a bandage. Once we get the limb compressed and down to a more closer to its baseline size, we can then fit you for a compression garment that you would typically wear to help maintain the compression and maintain the sizing of the limb. So that's more in the maintenance phase, which is the orange part. Again, exercise and movement is really important to try to encourage the flow of the lymph back. So the contraction of the muscles, the elevation of the limb can really help with allowing gravity to work in your favor and pull the fluid back. And then one other thing I'll talk more about on the next slide as well is skincare can be really important to prevent any complications. So that's probably the number one complication we see, is where there might be an injury to the skin. It can be harder because, like I mentioned, the lymph helps bring back, infections and other things, debris from around the cells. And so when that gets blocked up, that can get stuck there, and it's harder for the immune system to work in that area. So we really want to be careful about protecting the skin and moisturizing it. Again, wearing compression garments as directed, and we can help, make sure the garments are fitting appropriately and not pinching the skin. You may, like, reminding folks that you probably shouldn't be, if you can avoid it, it can't always be avoided, but if you can avoid having blood pressure or blood draws on a limb that has lymphedema, and then also protecting the skin from sunburns, or, wearing protective shirts to avoid scratches and other things. So it's important, like I mentioned before, to stay active with the limb to help the lymph move back, and again, protect the skin while you're doing all these activities. So there's a lot of exciting future directions for rehabilitation medicine, especially at UW and Fred Hutchinson Cancer Center. where we're working on enrolling patients in different digital health tools to help monitor activity outside the hospital, outside the clinic. I mentioned, gamification of it. It can help us as well to know, how active someone's being. Are they making the progress we anticipate? Are they, or maybe they're having a setback, and we can catch that a little earlier if we notice that, someone's not necessarily meeting their activity goals. And this really lets us have a personalized approach and have more longitudinal care where we have more touch points with our patients, so we can better understand, how can we really address the what they're experiencing. So happy to take any questions here at the end, and I think there's some pieces here in the chat as well. So
We can help you with the questions.
okay, awesome, thank you.
Okay, so the first one is, how long after treatment does lymphedema occur?
Yeah, this is a great question. So it can happen sometimes fairly quickly afterwards, but can also happen, sometimes up to years later. Sometimes I've seen folks who have it, arrive later, and there's not necessarily a clear reason why. There wasn't some sort of insulting event that triggered it. So it is one of those things that it's helpful to keep looking out for. And if you notice changes, circling back to the team as soon as possible.
Yeah. What do you suggest to help with chemo-induced neuropathy?
Excellent. Yeah, this is another great question, and I think comes up a lot. So I think with neuropathy can be a pretty tough symptom to treat. There's a handful of medications that have been shown to have efficacy in this area, and so we typically, one of the methods is to work through those medications, find ones you can tolerate at a level that are effective. Other times, alternative treatments. This is something that we work closely with our integrative medicine team as well. Some folks find massage therapy or acupuncture therapy to be helpful for neuropathy. We also find that sometimes activity can improve neuropathy, but one of the things, especially if it's really impacting the sensation in your feet or your hands, it can be important to have appropriate accommodations to protect your feet and make sure and to decrease your fall risk. So I think it's definitely a chronic condition that we help manage. And I think if we don't have a medication or something that can specifically reverse it, usually we're just trying to manage and reduce the symptoms.
Thank you. And we'll wrap up with kind of a twofold question. What recommendations do you have for patients flying with lymphedema other than compression stockings? And then the second component of that is, what do you recommend if lymphedema is more located in a joint and a patient can't necessarily easily get a compression garment for that area?
Yeah, these are great questions. And I think, when with a flight, we enter this lower pressure system, just being higher up in the atmosphere. And so it makes it easier for fluid to pool, and people typically experience more swelling, even if they don't have lymphedema. And so I think it's really important to be in close communication with your medical team just to make sure you're safe to fly with everything going on. But I think when folks do have a limb that has lymphedema, and we've been working with them and we've been able to get it compressed, I think people do fly successfully. Typically, manual lymphatic drainage during the flight can be helpful, meaning like massaging it. If it is in your leg, standing up, walking through the airplane as much as possible can be helpful. I think it's not necessarily a contraindication, but you may notice that the lymphedema, I would say most people notice the lymphedema does get worse during a flight. And so, again, like you mentioned, wearing the compression stock or compression garment during the flight, but also maybe being prepared to do some mobility of the limb during the flight, as well as if you can do any manual lymphatic drainage. And then for the second question for the joint itself, it's a great question regarding compression garments. There's some locations that's just a lot harder to get compression. And in those cases, we often have to rely more on the manual lymphatic drainage. And sometimes we can get custom compression garments that are able to fit into those areas. But to your point, there can be areas, especially in like the jaw or the face, where we have to rely more on the manual lymphatic drainage. If you're having significant, I didn't really talk about it in this on these slides, but if someone is having what we call refractory, or it's not lymphedema that's not really responding to manual lymphatic drainage, compression garments, there are pneumatic compression devices that can help with pushing the fluid back. And so those are something you can talk to your team about. And then finally, the kind of final treatment is talking to a surgeon. Sometimes there's opportunities, depending on the exact anatomy, to try to surgically recreate some of those lymphatic pathways to address the lymphedema.
Thank you.
Thanks so
All right.
much. Yeah, thanks for
We
having
really
me.
appreciate that. We're going to transition before our break to welcome Joe McNeal, who is the Executive Director of the Northwest Sarcoma Foundation. And she's going to share a brief overview of the foundation and the resources available right here in this region. Please welcome Joe. And I know that most of you may already know her, and we're just so grateful to have her and her community within our Pacific Northwest region to better support our patients with sarcoma.
Thank you, Dr. Schaub. Good morning, everyone. I'm going to see if I can get my slides to share here for a moment. Give me a second. Make sure I get the right one. Hopefully you're seeing the right one. Any thumbs up? All right, hopefully I got a thumbs up. All right. Well, thank you, Jeremy. So good morning, everyone, and thank you to Fred Hatch for inviting us to share about the organization, and to everyone for joining and learning, taking this opportunity to learn about sarcoma. I am Joe McNeal, as Dr. Schaub said. I'm the Executive Director of the Northwest Sarcoma Foundation. We are the oldest sarcoma organization in the world, but we focus on our support in the Pacific Northwest. Our mission is to provide hope and education support to anyone affected by sarcoma in the Pacific Northwest while investing in research for better treatment outcomes. For patients in the region, we provide, hold on, let me see if I can advance, do my slide. There we go. For our patients in our region, we provide financial support because we understand that cancer treatment can change your financial budget. Over the years of this program, we've provided over $1.25 million in financial support. Along with the financial support, we offer care packages to sarcoma patients in our region. Both of these programs are applied for by your social worker or patient navigator at your treatment centers, and we encourage you to reach out if you haven't had the opportunity. Each month, we host a casual chat for sarcoma patients and survivors. This is an opportunity for patients and survivors to connect, learn from each other, and provide support for each other. I believe the previous presenter mentioned support groups. We have that available. We also host educational opportunities similar to today's event, but they focus on specific sarcomas or topics that support you as a patient or caregiver. We have a researchers update night coming up in June on TGCT, which Dr. Davis mentioned earlier. Feel free to join us and learn more about some of the things that Dr. Davis touched on. Plus, later this year, we have a patient education night to help you understand wills, trusts, and power of attorney. You can register for any of our educational opportunities on our website at www.nwsarcoma.org. We are happy to share that we partner with many different organizations to help patients through their treatment. We partner with INA for nutritional support. It's an online platform. We partner with Sarcoma Patient Advocacy Global Network to keep connected across the globe with what's happening with advocacy groups. The Sarcoma Coalition is a group of advocacy groups in the US who connect and share information. Smart Patients is an online platform. They have sarcoma-specific space for you to learn and connect with other patient caregivers. If you're searching for a mentor to support you through your treatment, we partner with Immerman Angels. They will do their best to connect you with someone with a similar diagnosis. They're also searching for mentors. If you would like to impart any of your knowledge, please check them out. As I mentioned earlier, we are the oldest sarcoma organization in the world. We are turning 30 later this month. We invite you to this free event on Friday, April 10th. This event will include a lab tour at Fred Hutch. The event is hosted at Fred Hutch. And again, we encourage you to join us as we celebrate this milestone. We also have some upcoming fundraisers. In May, I invite you to join us at our Hope Grows Here event in Seattle on Thursday, May 14th. This event will be held on a boat near Fred Hutch, but we're not leaving the dock. So please come join us for this fundraising event. We also have the Dragon Slayer Fantasy Dash and Strut in September. This is a 5K costumed fun run with a villain zone, simple obstacle course in the middle. Please join us on September 19th in Seattle. If you would like to contact us, you can do so at info@nwsarcoma.org. We're here for you. We firmly believe no one should face sarcoma alone. Again, I thank you for joining this learning conference today, and we hope to meet you in person at one of our events soon.
Thank you, Joe.
You're welcome. I send it back to you.
Also, a lot of our social workers are work very closely with Northwest Sarcoma Foundation, and it can always make that referral if you forget the exact name and you're wondering, as well as us as providers.
Yes, please do so. All right, thank you very much.
We're going to transition to a 10-minute break right now. Thank you, everyone, for your engagement with us.
Yeah, welcome back, and it's my pleasure to introduce my co-host and co-moderator, Dr. Stephanie Schaub, who, as you heard at the beginning of the talk, is a associate professor in the Department of Radiation Oncology, and she will be talking to you about precision radiation therapy for sarcoma. Thank you very much.
Thank you for having me today. So this is our outline for what we'll cover during our time together. So some of you are no foreigners to radiation, but I just want to kind of help to explain in general what radiation is, how we think about it. Introduction to radiation therapy. Most of the time when we're talking about radiation therapy, we're talking about external beam radiation therapy. This is radiation therapy that is delivered by a treatment machine that can deliver high energy X-rays called photons or charged particles called protons. During this treatment, you see nothing, hear nothing, feel nothing. You're no harm to others. You're not radioactive. Radiation's only on for a few minutes when you're in an exact treatment position within millimeters of accuracy, and you're no different from when you entered the building to when you leave. And as side effects gradually accumulate over the treatment course, typically peaking about a week after treatment is over, and then just as they came on, they gradually get better in the time after that. So when is radiation therapy recommended for patients with sarcoma? Typically in a localized setting, we have a dominant role for patients with soft tissue sarcomas, particularly intermediate or high-grade tumors, and select low-grade tumors that have a high tendency for local recurrence or coming back in the site where it originated. Here we deliver preoperative radiation or postoperative radiation therapy, depending on the clinical situation. And most often these tumors are located in the extremity, such as the arms or the legs or the trunk. But as you know, sarcomas can happen anywhere in the body. The other situation in which we think about using radiation is retroperitoneal sarcomas, where I partner a lot with Dr. Sharib. And this is really a multidisciplinary discussion where select cases where we're concerned about planned close or positive margins or certain histologies, particularly liposarcoma, where we're concerned that they may have a higher local recurrence rate and an improved benefit from preoperative radiation, then we like to potentially have a conversation with the patient about the risks and benefits of radiation therapy. The other situation that we heard some beautiful presentations from Dr. Laidlaw earlier too is when the tumor has spread to other parts of the body in a metastatic setting. Here we think of radiation in the oligo Latin derivative for few in number. This definition can be varied, but in general, I tend to think of less than 3 to 5 areas of spread where surgical resection, as we heard about cryotherapy, or radiation therapy may be technically feasible to treat all areas that we see. The other situation that I believe local directed therapy, again, it doesn't need to be radiation specifically, can be considered is oligoprogressive, meaning a patient may be having a mixed response to systemic therapy, where there are only a few areas rather than many growing. And there we may consider local radiation, cryotherapy, or surgery to help treat potentially systemic therapy resistant clones to allow continued use of that systemic therapy if it is otherwise well tolerated. And the last category that we really think of is palliation to help control pain, or if patients aren't having pain in particular areas, but if we're concerned that if a tumor were to grow, that it could impact quality of life, such as a tumor near the spinal cord. So this is a concept that is really evolving within radiation therapy that I want to introduce today to you. I'm not asking you to be radiation biologists or physicists, but I just want to kind of skim the surface of what we're thinking about and what we're partnering with our medical physics colleagues as well, as we think about both designing each individual patient's treatment plan, but also as our the future directions our field is moving in terms of, what dose we're giving, the length of time that we're giving it, and how to do so both to be effective and safe. So this is going to be introducing you to some terminology. So each fraction of radiation is also one radiation treatment. Okay. Conventional standard fractionation is essentially giving radiation therapy in 1.8 or 2 gray per fraction. This is effectively the way that radiation has been historically delivered, and in many senses is kind of a gold standard for comparison of different treatment regimens. Hypofractionation, coming from Latin of few in number, is giving a higher dose per fraction, such as greater than 2 gray, over typically a shorter period of time. But how does one decide what treatment course is right for me? So introducing you to some information that gives our medical residents palpitations, but essentially some very basic principles of radiation biology. So every different tissue in our body and different type of tumor has different kinetics in terms of how it dies when it is exposed to radiation therapy. And so here is essentially a cell survival curve where here you see all the cells are alive and then they are incrementally dying with exposure to radiation therapy. So what we do know is that for tumor tissues, such as skin and other what we call acute or early responding tissues, essentially those tissues that we see the side effects during or shortly after the radiation course, those tissues typically have a large alpha beta ratio. Again, we have to quantify the effect of cell death so that we can then mathematically model how we expect it to respond. And that kind of number essentially comes from essentially seeing where the linear and a quadratic forms of cell death equal, and that is how it's derived in the lab. Again, I don't expect you to remember that, but essentially what we do know is that for those early responding tissues, if you give the radiation in one big treatment, or you break it up in the little d's, each dose per treatment, into smaller doses per treatment, there is less difference that we see in terms of that total cell death, and less advantage for those tissues in terms of breaking it up into those smaller and smaller treatment courses. However, for late responding tissues, and this is what we think of as usually slower growing tissues such as spinal cord, nerves in our body, kind of muscle fibrosis, those type of situations. There, they tend to have what we call a low alpha beta ratio. And essentially here, we can see that if we break our radiation into smaller and smaller pieces, we can sometimes get a differential benefit in terms of more protection of those tissues by breaking it into smaller pieces. And this is what we're kind of thinking of for every different kind of organ in our bodies. However, tumors also respond differently to radiation. And that is one of the reasons why, both in the waiting room and kind of hearing from other friends, why some patients with different types of cancer might be treated with a variable length of and dose of radiation therapy compared to what you might have experienced. And that is because certain tumors are highly responsive to radiation, such as liquid tumors like leukemia and lymphoma. And so those have an alpha beta ratio closer to 10, so less, sensitive to the impact of fractionation or kind of delivering smaller and smaller doses of radiation. However, sarcomas are felt to be slower responding tumors to radiation therapy, which is one of the reasons why typically when we treat the areas, we usually preface that typically after a radiation course, the tumor is about the same size, maybe a little bigger or smaller just due to internal cell death or swelling, but it's really over the months that follow after the radiation that we see the full effect. And the idea is that for tumors, specifically that have this lower number, that there may be less differential benefit in terms of actually fractionating heavily fractionating those tumors in terms of tumor cell kill. So the thought in the movement of our field is that it may be equally efficacious to try to find radiation treatment regimens that are in an overall smaller length of time, but a higher dose per treatment that are logistically more convenient. And so that's a big direction that our field is moving in. And so when we're really thinking about each individual patient and kind of designing these trials, we're trying to also compare to what we know. We can't just come up with random numbers. We want to convert those numbers that we're coming up with to a gold standard to conceptualize it. And so when you look at radiation therapy literature, we're often converting to what is called an equivalent dose in 2 gray fractions. Which is conceptually intuitive. It's like when you go to a country and you're exchanging your currency, often when you're still kind of looking and thinking when you're about to purchase something, what is this really in my own currency? So that you know if you're paying too much or too little for it. And rearranging the equation, another way of essentially conceptualizing it is called biologically effective dose. Essentially, what we want to accomplish is in many situations, we may tailor per patient, per situation, the amount of dose we're giving per treatment. But we want to do it in a way that we're being very thoughtful about giving a similar biological effective dose and that we're accounting for each different tissue in the body and how it may be differentially changed based on if we're giving it in a higher dose per treatment or lower dose per treatment. And so this is really an exciting evolution in our field for patients with localized sarcomas of the extremity, because historically this has been studied with the seminal clinical trials doing what is called conventional fractionation. So giving 50 gray and 25 treatments. So that's daily, Monday through Friday, over 5 weeks of treatment. And that is hard. That is hard because, many of you come from very far and it is, expensive to relocate yourself. It's hard to take that time off of work. But there are newer studies in terms of looking at doing this in what is called a moderate hypofractionation regimen, where it's delivered in a lower total dose, 42.75 in 15 treatments, such as 3 weeks, or ultra hypofractionation, such as 30 gray in 5 fractions. But importantly, as we're designing these trials and thinking about it, we always want to convert to that gold standard and make sure that the tumor itself is seeing biologically what is felt to be a similar effective dose so that we can hope and expect to see similar local control outcomes. Because when folks have studied doing these different dose and fractionation regimens using doses that are lower than this, we do sometimes see that the tumor control can be less than we hope. So the big picture concept essentially is that higher dose per fraction is biologically more intense, particularly for sarcomas. And this will result in a lower total dose of treatment, but that doesn't mean that biologically you're actually being treated with less radiation. We're not doing this in a silo within the sarcoma realm. We're actually about 20 to 30 years behind breast cancer, who has explored and really has moved towards standard of care being hypofractionation. So those 3-week regimens of radiation therapy to very similar doses compared to historically 5 weeks. And the data that we learned from breast cancer has shown that the late toxicity, meaning the late long-term side effects from radiation, seem to be about the same. If not, the cosmesis was slightly better using hypofractionation. And the breast cancer world has also started exploring doing it in 1 week compared to 3 weeks, just like the sarcoma world is doing too. And so what we do is while we're designing these trials, we also look at ancillary studies in similar areas to see what those long-term toxicities are to infer in terms of us thinking about kind of how safe and this may be to implement into our own clinics and practices as well. So kind of translating this information as well for patients within the metastatic or palliative setting is we're still using this information with a goal to achieve durability of local control, which means the tumor that we're physically treating, trying to prevent that area from continuing to grow or stabilizing it, while minimizing treatment-related toxicity. Doing shorter treatments can allow us to reduce the logistical burden of treatment. Again, we want to maximize your quality of life. Shorter treatment courses can often be better sandwiched between systemic therapies, and that allows us to minimize delays treating everywhere in the body while we focus on one particular area. And our treatment lengths can be really varied. Typically, in a metastatic setting, we try to range from 1 to 15 total treatments, but sometimes it can be longer. And this really is depending on the tumor size, the location, the sensitivity of the nearby structures, the history of radiation, the overall patient health, and the logistics. And so these are all things that we're trying to put into place as we decide what might be the right length for any given patient. And this is, that's a picture of one of our new linear accelerators or X-ray radiation machines located on the Northwest Hospital campus. So this is SBRT, or stereotactic body radiation therapy, is a type of radiation therapy that is a form of ultra hypofractionated radiation therapy. This is a, by Medicare definition, 5 treatments or less, although in Canada it's 6. But essentially, most importantly, what it's doing is we're using sophisticated X-ray based radiation to deliver beamlets of radiation kind of from around the body in the area that we're treating to essentially be able to achieve very high ablative doses of radiation therapy in the region that we want to target with an incredibly steep dose fall-off curve that allows us to be safe near the critical organs next to it, such as this is a spine treatment here, such as the spinal cord. And even though they're late responding tissues where you would say, didn't you just tell me you need to fractionate this heavily? This steep dose fall-off curve allows us with the increased precision to be able to deliver these treatments in safe and effective ways. And so it allows us to be biologically ablative. So our goal of these treatments are really to help prevent those to kill the tumor cells in those areas. Like Dr. Laidlaw mentioned, SBRT for lung metastases do typically have local control rates greater than 90 to 95%. Local control usually looks like some fibrotic kind of scarring in the lung itself. And the control rates for spine treatments can be greater than 90%. These patients are typically treated with mini CT scans performed directly prior to the treatment, and sometimes even midway during the treatment with an MD verification to confirm that accuracy before treatment is delivered. And so one of the slight nuances that you might have heard from during Dr. Laidlaw's lecture is any individual lung metastatic lesion might be very amenable to SBRT. But sometimes what we're looking for and what we're doing more and more within our multidisciplinary clinics is discussing as a team with our surgical oncology colleagues, IR, and ourselves of which ones would be amenable to what type of tool so that we can best use the most effective tool for that area, knowing that sometimes the low dose of radiation when we treat many areas within the lung can result in a risk of increasing radiation-induced side effects to the lung. And we want to keep that as low as possible for patients. And so those are the situations where sometimes we say, if we have another effective option for that, let's go for it. And then we can always, treat something later down the road. And even cryotherapy to lesion, God forbid, should it come back, wouldn't necessarily preclude our ability to deliver radiation. And so the last topic I want to introduce during our time together, particularly because we have access to it at the Fred Hutch, is a special type of radiation called proton therapy. This is a type of radiation that has a physical property of no exit just beyond the tumor that you're treating, and that for select circumstances can allow for sparing of nearby critical organs. Here is an example of kind of traditional X-ray based radiation, where you come in with different radiation beams to treat the tumor that you want to see. You have an entry dose of radiation no matter what, but you do have the exponential dose follow-up of the X-ray radiation treatment. With proton therapy, you still have the entry dose of radiation, and you still have to treat the margin for microscopic potential extension of disease and set up uncertainty. But the advantage is that you have no exit dose. The experience is otherwise identical for the patient. And so the situations in our practice that we tend to think of it the most, although anytime we see a patient, it is kind of part of our evaluation process, is in the reirradiation setting, where that lack of exit dose sometimes can help us to limit the overlap between previous immediate or high dose regions. Head and neck or sinus tumors, particularly when you're treating kind of one side, like one side of the neck, because that allows us to better spare the salivary glands on the opposite side. And sinus tumors, because you can better spare the eye and optic structures by kind of treating between that location. Larger thoracic tumors, particularly those draping in front of the heart, we use proton beam radiation therapy to provide heart sparing, as well as some larger tumors that can help us reduce the radiation dose to the normal lung tissue. Well lateralized retroperitoneal sarcomas, those are the sarcomas within the belly region. This is a situation in which we think of if there is typically, one kidney remaining. And so really you want to limit that low dose to the contralateral kidney if you're near it, as well as if it's not kind of surrounded by bowel or other things that can lead to a lot of dose uncertainty with proton radiation. Pelvic tumors, especially when they're localized to one side, again, that concept, if you have a tumor right in the middle, you still often need to come in with radiation beams from different directions, so that lack of exit dose isn't as beneficial compared to if it's kind of off to one side. But they are, in many situations for our young adult patients, both male and female, we're able to limit our radiation dose to the testicles, the uterus, and ovaries to help preserve fertility. And spine tumors, particularly those chordomas and chondrosarcomas. These are tumors that require very high doses of radiation therapy for durable local control, and they're often next to the spinal cord, bowel, or other nearby critical structures. And there we leverage proton therapy to allow us to get in as much dose as humanly possible, while safely so, and have those deep fall-offs near those critical organs. But we don't use it for everyone. And that's because there is an urgency component sometimes to radiation. A simple X-ray plan can be generated in hours to days, and proton therapy can take weeks to generate a plan. If a tumor is located in an area where there's no critical organ, such as the ones that I pointed out, that can be better spared with protons, such as tumors in extremity, we actually have a little bit more of skin sparing properties with X-ray based radiation. And anecdotally, I do feel like protons might have a slightly higher wound healing complication rate, but we accept that if it's really sparing something else meaningfully beyond it. Logistics, travel, and insurance. There is limited availability of proton therapy. We are the only center in the whole Pacific Northwest region. The next nearest center with our technology is San Diego. Um, but it can, the financial toxicity of treatment could be substantial if insurance wouldn't cover it. On hardware, certain hardware can actually create a dose shadow. As with particle therapy, this is different than X-ray based radiation therapy that is less susceptible to this. And that means that I cannot meaningfully get dose around or beyond that tumor or that hardware apparatus. And therefore, I would be undercovering the area that I would intend to treat. And I never want to undercover somewhere that we want to give full and effective radiation dose. There are new advancements of hardware, such as carbon fiber hardware. Carbon is just like the bones in our body. And so there we can effectively treat with proton therapy. And we work with our surgical colleagues when and if we have opportunities to use advanced hardware that are compatible with protons for spine tumors, we do. And sometimes, especially for smaller tumors, like I pointed out, like small lung tumors, spine tumors, small bone metastatic lesions, sometimes the dose distribution, that really high ablative dose, is better and more safely delivered with the traditional X-ray radiation therapy, such as using SBRT or more sophisticated tools. So thank you for your time. I've just kind of tried to glimpse upon the surface of some of the directions that we're moving, as well as kind of the considerations that we're thinking about as we design a radiation plan. And I appreciate that we do have limited time. I'm happy to answer a couple questions, but since I'm a moderator as well, I'm happy to also answer some via chat. Thank you.
Thank you, Stephanie. Dr. Schaub, every time I came up with a question, I feel like you answered it. But we do have one in there in the chat that just popped up. It says, "What is the difference between 3D CRT and IMRT radiation, and/or are there any differences in effectiveness?" And what we may only have time for one question,
I
but
I think that's a perfect question because many insurance so both types of 3D conformal radiation and IMRT are both X-ray based radiation therapy treatments. So the 3D so if you envision 3D conformal radiation is essentially hand selecting the beam angles that we're picking, and it's kind of more forward planning for the radiation therapy. For very lateralized tumors or certain locations, especially on extremity, sometimes we can come up with an excellent 3D conformal radiation plan that looks almost identical to the IMRT plan, which usually has about 7 to 11 different beam angles or partial arcs in which the X-ray radiation is delivered. And in those circumstances, sometimes from an insurance standpoint, we will find that they are equivalent and effective in terms of the radiation treatment and the long-term toxicity outcomes. 3D conformal was historically the type of radiation that was used on many of these clinical trials. But when we find that tumors wrap around a femur or a long bone or have very little skin sparing, we can often do much better in terms of kind of scoping the radiation, just leveraging more of those beam angles, such as using IMRT. What we do is many insurance companies are requiring us to generate what we call comparison plans, showing that it would be that IMRT must be absolutely necessary to be able to kind of best spare all the organs that we're sparing before approving that. So it is something that comes up a lot in clinic. What I would say is that we're very strong advocates, and when we feel like a certain plan is needed to be able to be safe and most effective, we'll continue to like advocate through the appeal process. And there are times where a 3D conformal plan is actually very elegant and beautiful. And those are times that we'll say, okay, actually, let's move forward with this. As a default, we usually request IMRT, but it does come up a lot, unfortunately. But no matter what, a patient's radiation course, especially with X-ray radiation for like preoperative sarcoma, should always be covered. It's just a matter of exactly what tool, but they should be similarly effective.
Thank you, Dr. Schaub.
I'm actually going to introduce the next speaker, who is also a radiation oncologist, Dr. Shannon Fogh. And she's an associate professor at the Fred Hutch and University of Washington in both radiation oncology and the Division of Hematology and Oncology in the Fred Hutch Integrative Medicine Department. So thank you for joining us today to share your expertise on integrative oncology.
Thank you so much for having me. And I'm just gonna, can everybody see my slides okay?
Yes.
Okay, perfect. I'll just start with just a brief introduction to what we are referring to as integrative oncology. Just stressing that this is really a patient-centered, evidence-based, informed area of cancer treatment that really is designed to synergize with our conventional treatments. The goal is to optimize our outcomes, improve quality of life, and again, really collaborate with your oncology team to take advantage of the best evidence-based approaches. And under this umbrella includes things like nutrition, supplements, mind-body therapies, and of course, movement and exercise. And in spite of the fact that we have some of the weakest evidence for supplements, this is actually one of the most common things that patients come to our integrative medicine group asking about. And so I just wanted to discuss some of the things that we talk about with patients. And just importantly, always making sure that when we take a supplement, we want to make sure that it's not going to interfere with anything with therapy or with potential creating any potential side effects. So thinking about, is something an antioxidant? Could it potentially be a blood thinner? Could it impact the immune system in a way that could interfere with any of the systemic or chemotherapies? And again, our goal is to really improve outcomes and not add anything that could potentially interfere with the therapies. I'll just give a brief summary of why, for example, we don't want to take ones that have high antioxidant properties. When we're thinking about radiation therapy, this is actually designed to create free radicals that impact the tumor cell's DNA. So we don't want to do anything with a supplement that could potentially undo this. By the way, everything through food is fine. So we always encourage people, they can still have blueberries, they can still have foods that have antioxidant properties, but we just want to stay away from those mega doses. Like when you look at the back of a supplement and it says it has 10,000% of vitamin C, that's not something we want to include during radiation therapy or potentially other therapies. As I mentioned, thinking about things that could impact bleeding risk, and if patients are preparing for surgery, supplements that you may not even ever think about having this risk, like vitamin E or fish oil, even turmeric, can potentially be blood thinners, and we want to be aware of this. We want to make sure that we, just because we're adding something that we think of as improving outcomes or could be healthy, that it may not be contributing to worse outcomes or even new cancers. Just some examples, vitamin E and selenium have been shown to increase the risk of prostate cancer. Vitamin A can be associated with increased risk of lung cancer in smokers. And there can be other supplements that could actually increase the risk of cancer. So we want to be mindful of that. I have a lot of people who have been talking about the microbiome. It's all over the internet, and thinking that we have, the right probiotics that could potentially be helpful with this. we are not at the place yet, and I'm going to talk at the end of this talk about some strategies to help take care of the microbiome. But I will just say with probiotics, making sure that if you're in a place where the counts are low, or you might be on steroid therapy or on certain therapies, we want to be really careful that we're not adding bugs that may be, our body doesn't have the ability to really process. And so being thoughtful about that. And these are just some examples, including having a central venous catheter or even a history of diabetes. And this is just a table summarizing some of the things, again, potentially benign over-the-counter supplements that can interfere with some of our therapies. We also want to just be thoughtful about where our supplements are coming from, that it has what it says it has in it, that doesn't have things we don't want in it. There can be a lot of variation in the content of products. We want to make sure that they don't have something like mercury or lead. Just being, again, in the spirit of if we're taking something to improve outcomes, that we're not potentially taking something that can be harmful. I didn't add this to the slide, but because there's so much now in compounding pharmacies, about 30% of those compounded products have been found to have things in them that are not good for us. So to be aware of that as well. This is just some examples of places where you can check for supplement quality. I'm a big fan of consumerlab.com, and you can actually get a free subscription to that through the Seattle Public Library. What I like about it too is it lists the supplements in all ranges of prices. So you can get a good supplement that doesn't have to be the most expensive brand. For vitamin D, for example, one that might cost $5 or $6 versus one that might cost $80. There can be a lot of variation in Consumer Lab. If it's an approved product, this is a great way to find a less expensive but good version of a supplement. And so while everybody is thinking about supplements, some of the areas we have the best evidence for are actually exercise or movement and mind-body approaches. And just some of the benefits of our mind-body approaches include improving fatigue, cognition, really helping with brain fog, even helping with things like anxiety and depression. They are lowering our cortisol levels, lowering inflammation, and actually increasing some of our good brain waves. This was a study that looked at patients who did a 4-week mindfulness course, and that cortisol level was something that was impacted even with that brief intervention of a mind-body approach. As I mentioned, inflammation can be lowered. So many people are seeking to take supplements that lower inflammation, and our mind-body approaches can do this as well. I mentioned having good brain waves, the kind that can help us with relaxation, problem solving, that can be improved with mindful practices. And again, getting good blood flow. This can be something that's helping with the way we think, cognitive challenges, how we help or process and think through information. There's so much under the mind-body approach. I have a lot of patients come to me and say, well, I have to learn to meditate. And that's actually not true. That's one under many things under this umbrella. And in fact, sometimes it's hard if you're in the middle of therapy, might be having some symptoms or discomfort, to be in a place where sitting still and training your brain to just be quiet, that may be more challenging at this period of time. So things that I think are really helpful to keep in mind is that there are so many different types, different voices. If you were listening to different meditations, thinking of it as the practice of meditation. And a couple things that I have found to be really effective is just being in nature or doing something creative, photography, coloring, watercolor, sitting on a bench in a park. These actually can be effective mind-body approaches. So it doesn't have to be something where you're sitting cross-legged on a mat to get the benefits of this. Acupuncture is something that can really benefit patients, and many benefits, including helping with fatigue, sleep, stress, anxiety, pain, nausea. We also have a nurse that on our team that teaches acupressure for many of these symptoms, so that can be a helpful thing to add. I know you heard from the rehabilitation team earlier, so I'll just quickly say that exercise has many benefits: functional status, quality of life, and even survival. Going back to just things that can help cognition or brain fog, This is something that exercise can produce what we call brain-derived nootropic factor. This helps with neuroplasticity and connectivity, impacting the structure and the health of our hippocampus, which is a structure that helps us with memory. Even one bout of exercise can actually improve this. Exercise is also something that counterintuitively can help with fatigue, and the potential mechanisms may be related to creating better and healthier mitochondria. I mentioned that it can impact survival, and we see this across all different kinds of cancers. This happens to be a study looking at patients with brain cancer who did greater than 9 MET hours per week, and we saw that actually benefiting their survival. And just to briefly say what a MET is, this is really our equivalent task, and I show this to also just stress that really any movement counts. So sweeping, housework, walking can all be forms of exercise. 21 MET hours a week is the equivalent to walking about 7 hours per week. So in the study I showed previously, 9 MET hours is really just a few hours a week of walking. And again, any movement counts. And I'm just going to skip past this because I think you heard a little bit about this earlier, but know that the prehabilitation and rehabilitation have been shown to really positively impact outcomes, and such an important thing to be incorporating. I mentioned briefly the microbiome and how we're seeing this associated with many different outcomes. And so I just wanted to briefly touch on this. Where we see changes in the microbiome with cancer can be things that precede the diagnosis, but also the treatments can impact our microbiome, and even stress can impact our gut microbiome. The gut microbiome can actually then impact outcomes and also impact some of the symptoms that we have during our treatments. And there are many things that we can do that fall under evidence-based approaches that don't necessarily include going to find a probiotic that you take. That our nutrition, exercise, vitamin D, and mind-body approaches and sleep can all positively impact our microbiome. Vitamin D levels, and there are so many reasons also why we want to have healthy, good vitamin D levels, but this has been linked with greater microbiome richness. We see even when patients take a vitamin D supplement that this actually helps improve their microbiome. I mentioned exercise and having all the benefits that we talked about. It can actually also increase microbiome, and it turns out that having bursts of more intense activity can increase the health of our microbiome. Sleep can help the health of our microbiome, so important to make sure we're getting enough sleep. And in this study, it actually shifted some of the better bacteria when people got more sleep and less of the not so good bacteria. And our nutrition can play a role as well. And so I mentioned getting good probiotic foods, and these dairy-based foods can include things like yogurt, cottage cheese. Non-dairy foods can be things like fermented vegetables, kimchi, sauerkraut. And the other thing we can do is really think about the variety of plant-based foods we get. This was a study called the American Gut Project, where people had patients that had greater than 30 plant-based foods a week actually had much healthier microbiomes. And I just want to stress that that included nuts, seeds, legumes, not just fruits and vegetables, and it wasn't portions. Herbs and spices, for example, counted. If you put a couple basil leaves on a salad, had cinnamon, turmeric, those all counted towards that food variety. And this is really one of the best ways that we can support our microbiome. And I bring that up because there's been so much discussion about ketogenic approaches. And this is just a wonderful study that showed when we have a diet that includes more whole food plant-based versus just a strictly ketogenic diet, we can actually get all of the benefits that people are striving to get with a ketogenic approach: lower glucose, lower weight, lower insulin, lower inflammation. But with a whole food plant-based approach, we also get the benefits of fiber, phytochemicals and flavonoids, butyrate, which is good for our gut. So this is really how we are encouraging patients to approach their nutrition, and just pointing out that there can be a lot of things that we want to be aware of on a ketogenic approach that need to be monitored by somebody who has experience in this, including risk of kidney stones, constipation, and we want to be thoughtful about that. Just because I'm at the end of time, I'll just say a couple of, when people are always thinking they have to do ketogenic to keep their sugars in a good place, simple things that you can do, having your vegetables first in your meal, that helps the fiber actually helps mop up the glucose levels and keeps insulin from coming in and overdoing it, or taking a short walk after a meal can be simple strategies. And just thinking about what we call our glycemic index of our food. For example, a white potato hits our bloodstream like a spoonful of sugar. A sweet potato is half of that. So that can be something that's helpful, or pairing foods with good, healthy fats that helps keep our sugar levels in a good place. And we're still getting all the benefits of the fruits and vegetables and that variety. Thank you very much.
Great. Thank you so much. Really appreciate all that information. I think we maybe have time just for one question. And there's a lot of different recommendations or kind of different directions that patients should go. If you're an individual patient thinking about, what sorts of things should I focus on and where should I start in terms of trying to get some of this information more on an individual basis, what would be your advice to patients who might be listening?
Yeah, well, if you're at Fred Hutch, we have 5 practitioners in our integrative medicine. So that can be a great way to just like come in and talk with us and, have a personalized, customized overview of, what we would recommend. And we also do a lot of, okay, implementation. How are we going to help patients implement this? It's one thing to tell somebody to go out and exercise, and another thing to really think about what barriers they might have, whether they're physical, functional, we really want to work with patients and individualize that. And yeah, so that's, if we're Fred Hutch patients, that can be a great way. We have resources online like Cook for Your Life, which is a great source for recipes and, different foods that are great for fighting cancer. And I would just say, don't get caught up in the influencer. There's so much information out there. So, really talk to your team, talk to your doctors, and, remember, natural is not always better. Poison ivy is natural, but it's not good to rub it all over us. So.
Great. Well, yeah, Dr. Fogg, thank you so much. And I believe that any of us can write a referral, so that should be an easy way to get in.
Yeah.
So yeah, without further ado, next I'd like to introduce Natasha Nathan, who's the program management manager for engagement and advocacy at our second sponsor, the Sarcoma Foundation of America. So Natasha, if you're ready,
Hi,
welcome. Thank you.
how's it going? All right, let's see if I can pull up these slides. All right. Great. Can everyone see those? Looks like you can on my end. So awesome. Thanks, Jeremy. Great. Well, as Jeremy said, I'm Natasha Nathan, the Program Manager of Engagement and Advocacy at Sarcoma Foundation of America, and I'm also a rhabdomyosarcoma survivor. So sharing with you SFA's mission, you can obviously read it, but it's to improve outcomes for people diagnosed with sarcoma and increase the number of survivors, simply put. We do this by funding and advancing research, educating and providing resources for people diagnosed with sarcoma, and advocating on the behalf of the entire community and bringing together the collective sarcoma voice. So I always say we have like 3 main pillars at SFA that all of our programming falls under, and that is research, education, and advocacy. To throw it back, now almost 26 years, we're in our 25th right now. We were founded by Dr. Mark Thornton, Tricia Thornton, and Dr. Jack Brooks in 2000, which was really born out of Mark and Tricia's experience with their 3-year-old son, Jeffrey, having sarcoma, and them identifying a need to support patients and families experiencing sarcoma. So really grassroots, born out of the Thorntons' basement, and all of these years later, we are still working on the foundations that they built. They're still deeply involved, but the main thing was research. And we operate under the belief that a path to a cure for sarcoma is research, and that is at the heart of everything SFA does. We are the largest sarcoma-specific private funder of research in the sarcoma community, and that has amounted to investing over $27 million in sarcoma research in the last 26 years. So we do fund research globally. We do now actually have a staff member in Europe to help support our global efforts. So our name is slightly misleading, but we do fund research globally. Education is the other main pillar at SFA, and that's really of the belief that an empowered community, an educated and empowered community, brings forward change. So not only does that aid patients and caregivers in advocating for their own care, but it also helps build a network of advocates on behalf of others throughout the entire community. So we do have many inpatient, in-person education sessions, interactive webinars, advocate trainings. We're actually in the process of working on a research advocate training as we speak, and briefings on the latest developments in sarcoma research. So you'll see that in almost every newsletter we have going out, just so that patients are up to date on the latest in the space. We also have many resources to support patients, and these are just a few. But one in particular that I always like to shout out is Jordan's Dream Fund for clinical trials. This is to help patients with the cost of clinical trial. So we are always accepting applications for that. We have a really comprehensive list of all of the sarcoma subtypes, and I always like to shout that one out too because it saves you from the Google rabbit holes that everyone tells you not to go down and really just gives you the information you need about your subtype. In addition to sarcoma treatment centers, all of the treatment centers on our website go through very rigorous grading to make sure that they are the best in sarcoma care. So if anyone is looking for centers near them, and obviously we have the amazing Fred Hutch, but if patients do come to us looking for a sarcoma center for treatment, we have them listed there. The diagnosis question guide is another amazing one. I know for me, when I was diagnosed, I had no idea what to ask. And this is exactly that. It's conversations you should be having with your care team at a second opinion, at your first opinion, all of the things that we know it's important to cover. We've recently launched Sarcoma Match, which is in partnership with Immerman Angels. That was actually born from our adolescent young adult committee, speaking to how badly they wanted a mentorship program. So powered by Immerman Angels, we do now have that. And then Sarcoma Stories is our podcast. It has grown quite a bit since it launched in November 2024, but it's a place for patients to share their stories, connect, and learn from each other. You can hear from every professional in the world, and sometimes it just takes hearing something from a fellow patient to really land. And so it's been amazing to see that community grow. And then advocacy. Our goal is really to be the voice for the sarcoma community. In the past, I believe it's the last 2 years, we have actually formed a group with the other sarcoma patient advocacy groups to really come together and advocate on behalf of the entire community. So through that, we now host our annual Hill Day or Advocacy Weekend, we call it, every July during Sarcoma Awareness Month. And so while we have a designated weekend for that, we are year-round advocating on behalf of the community by educating legislators, federal and state agency officials about sarcoma and the needs of the community, especially the need for additional research and new therapies. And of course, increased research funding, especially in today's day and age. And just if you are interested in getting involved, this year's Advocacy Weekend is the 16th through 18th in Washington, D.C. So that is made up of one day on the Hill, which you can see last year's group here, meeting with legislators. The 17th is an education day that we reserve for learning about drug development process and the role advocacy plays in this. And we close it out with a nice celebration for our National Race to Cure Sarcoma, which is a part of our National 5K series. So if you do have any questions, you are always welcome to reach out to us at SFA at programs@caresarcoma.org.
Thank you so much.
You're welcome.
Our final speaker today will be Maribeth Lopit, who is our Director of Philanthropic Gifts at the Fred Hutch, and she'll be sharing a few words about how generosity can just help provide more opportunities for future improvements for patients.
Excuse me. Thank you, Dr. Schaub. Let's see. Are you all seeing my slides?
Yes.
Okay, awesome. So hello and now good afternoon to everyone. I'm really glad to be here. As noted, I am Maribeth Lopit, Director of Philanthropy at Fred Hutch, and Fred Hutch Philanthropy is very proud to raise funds to fuel the adult oncology program on behalf of both Fred Hutch and UW-Medicine. And I'm very proud to be fundraising liaison for our brilliant sarcoma faculty, who you've heard from here today. So I want to start by talking a little bit about Fred Hutch and why our organization is so special. Fred Hutch is a leader in cancer and infectious disease research and care. Our more than 6,100 clinicians, scientists, and staff work together to advance innovative research and compassionate care. Fred Hutch is an independent nonprofit organization that also serves as the cancer program for University of Washington Medicine. And we just celebrated our 50th anniversary. So, science builds on science. Our focus on innovation goes back to 1975 when Fred Hutch led the development of bone marrow transplantation to treat and ultimately cure many blood cancers and other diseases. So bone marrow transplantation offered the first clear proof that the immune system could be used to overcome cancer, laying the groundwork for what we would become the field of immunotherapy. Our belief in constantly improving and that the patient experience guides our science still drives our approach today as we set ever higher standards of care. The same spirit that drives us to continually improve treatments, so much of what you've heard of today also drives us to ensure people don't just survive cancer, but thrive in the years after their diagnosis and treatment, and that more cancers are prevented before they even begin. So this comprehensive approach and our experts' ability to work together to tackle cancer and infectious diseases from every angle is made possible through generous support from people like you, our patients, partners, and donors who share our commitment to transforming care and outcomes for all. We're in the midst of our $3 billion campaign for Fred Hutch, which will radically increase the pace and scale of innovation and redefine cancer and infectious disease for generations to come. Our community is fueling extraordinary leaps in science and cancer by helping us to empower our scientists and clinicians to pursue their boldest ideas, expand support services for patients and their caregivers, retain our world-leading talent while training the next generation of researchers, and fostering research into health disparities to improve care for every person experiencing cancer. In philanthropy, we are driven by the unique motivations of every one of our donors. We work with donors, many of whom are patients, to understand their reasons for giving and to make the impact each finds most meaningful. So every donation of every size is part of this bold vision. And there are ways to give that that matter. So philanthropic support is more flexible than any other source of scientific funding, allowing our researchers to quickly follow where the science leads, answer emerging questions, and develop proof of concept for new ideas. And as I said, all gifts matter. There are many ways in which members of our community choose to contribute or share their support. And we are grateful to people who have generously donated once or many times, who have included us in their will or estate plan, or have volunteered or advocated for our work, or as Jeremy had mentioned earlier, participate in Obliteride. There are many ways for people to be involved. So your support provides us with funding we need to plan for the future, to follow the science where it leads, and be ready to drive new discoveries forward as quickly as we can. Here are a few other ways to get involved, as I mentioned, and some contact information and links, which I believe these slides will be shared. So by volunteering at Fred Hutch, Obliteride, Swim Across America, Base to Space, all of these offer opportunities to advocate for Fred Hutch and offer support. So if I can be of assistance as a Fred Hutch Philanthropy connection in the future, please don't hesitate to reach out to me, and I would be happy to connect with you. So thank you. Thank you so much for allowing me to be part of this. And now to remove this. Let's see here.
I think just
Sorry, I'm not accustomed to
there we
Zoom.
go.
Am I? Okay, thank you.
We're using Teams, I guess, a lot. Maribeth, thank you very much for that information, and thank you to all of our speakers for today. I think this was very informative, and we learned a lot about many of the different aspects that go into the care for sarcoma, particularly here at Fred Hutch, but in general as well. Um, I have up here the couple links for feedback for today's event. We're a couple of minutes over time, but I think we did a reasonable job at sticking to what we had hoped to accomplish. And if you fill out the QR code here, we'd really appreciate any of your feedback, and we'll try to implement whatever sort of suggestions come in for the following years. I also had mentioned that our primary event for the year, the Fred Hutch Obliteride, will be opening for registration this week, and we'll send out our sarcoma team QR code as well for anyone who wants to either join or support. And we'd love to see you out there one way or another in that regard. And otherwise, I hope everyone has a good Sunday, and we'll see you next year.